the most talented pool of vibrant people. It is our pleasure to welcome you all to the NICE Conference Live 2023 from April 27 to 29, 2023, here in New Delhi, India. This meeting will be featuring a 3-day comprehensive program with eminent speakers from across the world who will deliver high-level scientific content, perform live and recorded cases and workshops. There will be an opportunity for every practitioner to learn more about the specific topic and present e-posters and interesting neurointervention cases. We are certain that all of you will find every part of the meeting today stimulating and meaningful. Don't miss the incredible experience with our experts all across the world. More than 35 live neurointervention cases with discussion and brainstorming. Stroke live recorded cases, basic and advanced courses of aneurysm, stroke imaging, workshop, live demonstration and training on state-of-art models, live robotic neurointervention cases. As I said, it will be quite a remarkable day for all of you. We would now be starting with the first session of the day. But before we begin, can we have a round of applause for all the wonderful, distinguished, venerated guests present here with us? Thank you once again for giving us your precious time here today. Our first session is about to begin now. I would request the humble presence of the moderator of this session to kindly come here on stage and take the lead. Let's welcome Dr. Gaurav Goyal with a round of applause, please. Followed by our panelists now, starting with VP Singh, Lauren Perot, Anand Alurkar, Stephen Schaub, Yong Samson. Let's welcome our panelist, our venerated guest here on the dais with a round of applause. So most welcome. Please come. Everybody, can we welcome them with a round of applause, please? Thank you. Thank you so much. I would now be requesting the moderator of the session, Dr. Gaurav, to take the lead here.
So, while just we are waiting for our panelists to come up, may I request Dr. VP Singh also please to join us. So, it's customary to do inauguration on things, but we are skipping on that part. And I'm just going to request Dr. VP Singh, who is the chairman of Medanta Neuroscience Institute at Gurgaon, to welcome you all to this meeting. Sir, please, before we start, can you do the welcome? Sir.
Hello. So good afternoon, everybody. Dignitaries on the dais, off the dais. It's my pleasure to welcome you all to this meeting, which is being held after a long time. I think COVID did create some problems in our education program, but things are better now, and we are very happy to have this in-person physical meeting here. The Medanta Institute of Neurosciences is a very unique sort of place. You know, often we run into our silos, we remain neurologists, neurosurgeons, interventionists, with often the doctors not even talking to each other. Here we have a team consisting of neurosurgeons, neurologists, interventionists, mental health people, psychologists, the critical care team. And what is unique is that we talk to each other and the patient gets the best possible treatment. And there are no sort of silos, there are no sort of things. Everything is directed towards patient care and how we can do it well. Gaurav has been an integral part of our team for many years. He's spearheading the intervention department along with Anshu. Both of them are doing a wonderful job. We talk to each other every day. We get our patients of strokes, aneurysms taken care of appropriately. And obviously, he's taken away most of my cerebrovascular work. But the difficult cases where he gets stuck, he calls me and we sort of help him out. But as I say, the only constant thing in life is change, and change is a must. And we are changing and evolving to give better care for our patients, and that is ultimately what matters. I would like to welcome all the foreign faculty who have taken the botheration to come here. We learn from your experiences, and we do hope to have a good interaction with all of you. Unlike conferences where people are just presenting slides, this is where you're going to get a hands-on experience with live cases. So I'm sure NICE is going to be a very, very nice conference. Thank you for all.
Thank you, sir. And I just have few housekeeping announcements, and then we move on to the cases. So as you know, this is our first attempt to do live cases from many centers, and I'm glad all the centers are participating from across the country and globe. The good part about live cases, it excites us. There's a challenge of unpredictability, but sometimes the time and other things are not in our control. So please do not mind if we are overshooting the time. It may happen that we have started a case in one session, but it may end up in the second session. So we will keep changing the time sessions according to the time, may not be according to the case, whether we are able to finish them or not. Second thing, you will see a big QR code, and can we show the QR code in the center? So you can scan that QR code. You don't need to download any app, and that's the QR code for that Slido. And you can send your questions directly from your devices. Intermittently, we will also do the polling. You can do it from your phone. So it's very simple. Just scan it. Can we go to the next page? Once you have scanned it in your browser, and just make sure it's not in a cognito mode or a private browsing mode, and then it's going to stay there. Can we go to the next slide? Okay, I can do it from here. Yeah, sure. So this is how it's going to look like. Just enter your name, and then you can start typing your questions. Moderators will have iPads in front of them. Panelists will, moderators and panelists, they can reply if they want to reply silently, or we can discuss it towards the end, all the questions. And in between, we are trying to introduce a new concept called as flash workshops. So none of you know when they will be announced. Faculty who is there has been briefed that they will be called upon. So this will happen in the trade area in one of the booths. So this sort of a flash will come in between the sessions, that these workshops is going to happen in next 5 minutes in this tech suite, and these faculty can help you with the hands-on training, the tips and tricks about those devices. So you don't need to stick in the hall. You can move out, stretch your legs, come back. And it's a short workshop of 10-15 minutes, nothing long. So it's like a flash dance. So it's a flash workshop. I hope you're going to enjoy that. And there are not many lectures in this hall, but I will still request that we adhere to time for those lectures. And if we are overshooting, the AV team has been instructed to shut down the screens. As Dr. VP Singh said, we had an interaction. So this is a fully interactive meeting. Feel free to ask anything. And it's not a formal atmosphere. There's another hall called Stroke Hall or Hall B, where we have dedicated lectures and discussions between stroke neurologists and interventionists. Feel free to join that group also. So with this, we move on to our first case. And can we have the slides for the first case? It's going to come from NIMHANS, Bangalore, my alma mater. So I thought it all started way back from NIMHANS, so it should go back to NIMHANS and start back from there. So I'm going to show you the case. Arvind, my friend, is doing this case. I don't know if he can hear us, but he is live already. So next slide, we can go there. Yeah. No, I can't change the slide from here. Okay, I can? No, what I see here is not right. Okay. So he is doing a case of a CCF. This patient had a proptosis since 1 week. History of trauma, and there's some disconnect here. I can't see it. Yeah, so these are the case pictures which has been shared by them. So you can see it's a direct fistula. We can see the inferior petrosal sinus and superior ophthalmic vein being filled directly from the cavernous part of the ICA on the left side. It's a direct fistula. And next slide. Uh, yeah. So that's the high resolution which shows the rent. And I just want to have opinion of the house. How will they approach this? Can we have a poll, please? Triman? Okay, so maybe all of you can just scan. We'll take a minute to do this. So you can scan. And how will you like to do this? Transarterial, transvenous, both? So panelists cannot see the board. Okay, so most of you, and we can, answers are still pouring in, but I think overwhelming majority is in favor of doing a transarterial, and few of them are opting for both, and very few is going towards the transvenous. So next, please. Next poll, please. Yeah. So once you have decided the route, how will you prefer this to be treated? Like, do you want to just do coils? Maybe, just a parent vessel. You want to use balloon coil. You want to add a liquid embolic without coils. Some of us may want a flow diverter or a stent graft. Wow. There are a lot of people who like to do liquid embolic with balloon and coils. So I have never done with a liquid embolic in my own experience. I personally do balloon coils. I do not know what the panelists think. Stefan? You can use the mic.
So I would go for coiling as well.
Okay. So anybody in the panel who likes to use liquid embolic, because that's the overwhelming majority which we are seeing. Dr. Alurkar?
Yeah, I would go with balloon plus coil, and if required, liquid embolic.
Okay. All right. So that we can, sorry. This is the hardware which we're gonna use, and this is the pattern which we're gonna see throughout the day. So you can see all the hardwares which the center is planning to use. If they decide to change it at the last moment, they're gonna come back to us. And so the plan today for them is to do balloon and liquid embolic without coils. That's what the plan is. Can we go to Nimans now live? Yeah, Arvind, hello.
Can you hear us?
Yes, we can hear you loud and clear.
Yeah, thank you for all the opportunity.
So Arvind, we saw the pictures. And we discussed, and I think you are planning to use balloon and liquid embolic.
Yeah, that's what I've been doing. It all started some 11 years back, where we used to, initially when I was a student, we used to use balloons, then followed by coils later part. And it happened in one of the case where I was putting a lot of coils, and in India we have the cost constraint. The fistula was not listening, it was not getting closed. That's how this method came by, why don't we inject the liquid embolic in that?
Okay.
So from that time it started. So I've been doing this only with the liquid embolics.
Okay. So are you all set to show us?
Yeah. So this is a case of a 38-year-old male who had met with an accident, and following that there was a chemosis and proptosis. Now with the angio there is a fistula with a rent in the distal part of the ascending limb of the cavernous sinus. Actually the flow is directed laterally. I think Karthik can show. Flow is so this is where the rent is. So it is directed laterally and posterior aspect. So we are going to place the catheter in the sac, just distal to the rent and protect the rent wherever you put the balloon and inject the liquid embolic. This is what the plan is, and we'll go ahead with it.
So I'll request the panelists, like they can pitch in whenever they want. You don't need my, hint to say. So I think we can see your balloon is already in place and your microcatheter is already in the fistula.
Correct. It's there. My colleague Karthik is there with me assisting, so he will be taking all the questions.
Sure.
Right.
Access is to a neuron max, and the balloon is a 420 hyperclap, and that's parked across the ring. There's an echelon catheter that is across the ring and into the proximal aspect of the fistula. 1 minute. Shortly, we'll be inflating the balloon and
So if there are any questions, if there's nothing clear, you can always go on, put your questions there so we know that you want to ask this. Or there are mics around, feel free to reach out to the nearest mic to you, and there are some hand mics in the audience, we can ask them to provide to you.
So one question from the podium. So I'm just wondering, this patient is a good collateral from the controlled ICA?
There's not much of a steal from it totally into the fistula. There is an antegrade flow. I can show you the angiogram. You go to the diagnostic angiogram. Run number 3. Yeah. The steal is just partial. There's antegrade flow across into the supracranial IC. And now you can show the other side, the right IC image. So the anterior communicating system is patent. Nevertheless, the flow is, there's no need for any contralateral flow. It's just a partial steal. That's what I've intended.
Okay.
So we are assuming you're inflating the balloon now.
We're now starting to inflate the balloon.
Yeah.
I need a pointer. Just a small reposition. Now the balloon is flush across the line. We're going to inject the
Echelon catheter.
DMS. Focus.
So anyone in the audience uses just balloon and liquid embolic like Arvind? I think most of the people here like to put some coils and then liquid embolic because we are scared that it may either just fly off.
Now we're starting on heparin, just adding a bolus of heparin. Right now.
Yeah, please go ahead, Professor.
No, just two short comments. One, in France, we are very rarely treating such lesions because we don't see them anymore due to the fact that even when we have a car accident, it's very rare to have this kind of lesion. One, and the second thing is that we don't have anymore detachable balloon available in France, at least. I don't know in other countries in Europe. Probably also because the disease is very rare, and it's a main indication for detachable balloons. So I think in this situation we will do an option which was not proposed in your list, but it's not a problem. We will combine coils on the venous side with embolic agent, probably just to be sure that we will have a complete occlusion of the fistula. Yeah. What we can do also sometimes is to use a non-detachable balloon to control the carotid artery during the placement of coils and liquid embolic agent.
Yeah. So I think they are injecting Onyx now. So balloon is inflated. So he is slowly injecting, and Did you do the seal test first?
Cast of the onyx confirmed beyond the contours of the eye.
Yeah.
So that is a more reassuring sign.
But did you do the seal test first? Like, did you inject the contrast after the balloon to make sure there is no leakage?
Pre-procedure, before the telecast was started, we did try.
Yeah, so for the people, so most of the times before you do that, you inflate the balloon, inject a dye. That's your seal test. Your dye should not fly into the ICA. And that's when you start injecting your onyx or squid or whatever liquid embolic you want to use. And now we can see it's coming.
Just to put it into perspective, this was the orientation of the outflow of the star. The outflow of this fistula following beyond the ring. It goes posterior, turns lateral, and then medial. And that's the way the onyx is now percolating.
So the balloon is Hyperglide 420, and I think it's an Onyx 18 which you are using.
It's an Onyx 18.
It's an Onyx 18.
So we can confirm on the frontal it's going from posterior, lateral, and then medial. It's continuing with the injection.
So I want to make a small comment. Most of us do not have access to biplane cath labs. And I think on a single plane, it might be extremely tricky to know whether we are touching the balloon or not. So what do you say, Dr. Karapurkar?
That's true. So we'll have if we have a single plane, best to start it from an oblique perspective and dynamically move as we.
Hand mic.
It becomes a little difficult in a single plane. That is, we agree to. Recheck the program.
Sir.
I would be a little worried about injecting onyx, honestly. The reason being, when we used to treat giant aneurysms, we used to do the seal test as you said, and then we used to try and fill the aneurysm up. Many times, despite the aneurysm, the balloon being fully inflated, the ICA completely occluded. We did not get a complete occlusion unless the onyx also came into the ICA as a crescent.
From the more recent.
And so here we are, when you are injecting, some of it may come into the ICA despite the balloon.
Correct.
And when you deflate, that is going to stay in the ICA. So we've had that happen to us once in the basilar artery. So we are a little worried about using. So coils, the advantage is if you add coils, then you slow the. You don't need so much onyx.
Yeah.
Whereas here, just injecting, I would be a little worried.
So I have spoken to Arvind many times on this. So while he is doing the case, I can defend him. So I think
I know, I've heard him many times also. And he's quite gung-ho about it, and obviously he's got a...
Yes, so he has a huge series. He has a huge series, and as he said, there are financial challenges. So I think whatever they've injected so far is not even a vial. So eventually the whole cost of the procedure comes down significantly.
And to answer Laurent's, Piero's, the Bolt balloon is available in India. The Bolt detachable balloon. Bolt or Bolt, whatever you want to call it. We still have it. But I don't like to use it because I've had these balloons deflate and the fistula come back. So I don't like to use these detachable balloons anymore. We used to use the Nycomet detachable balloons with very good results. And we used those for almost 20 years, but they are not available anymore. The Nycomet gold valve balloon. What we have now available are the valve balloons.
So to answer the next question, which is there, I think they are injecting now for close to 6 minutes now. And the balloon, so it's an Onyx 18, and I think the balloon is still occlusive. Do you deflate in between, or you keep it inflated for how long?
Has been our practice to hold the inflation for an extended period of time. Reason being, sometimes we have noticed it trickle. It's not that it doesn't happen always.
Okay. So one inflation, you try to do this in one inflation only.
Yes.
Why not use a 34? Why is he using 18? Does he use 34?
They can hear you. They can hear you directly.
34.
Yeah, okay. Yeah, there's many
Not
juniors here, so I just wondering, when it comes to the CCF, I think we better start with the balloon occlusion test first. Then we are able to see whether we can occlude this ICA, or sometimes when it comes to treat this balloon, how long we can inflate the balloon. So I think, we have to start with the balloon occlusion test first, and then we are able to proceed with this procedure. This is, I think, very important point.
In this case, it's it's contextualizable. We could have done a balloon occlusion test, although the presence of the ACOM, and that's what gave us this reassurance. But yeah, we could have done it before we do this. We could have.
And what dilution you use for balloon? Is it 50-50, 70? 50-50. Okay. So.
One question I have. Have you encountered any complications during this procedure in the past? And
the reflux of this material into the parent artery has occurred once.
So I can see Arvind relaxing now. So what are we waiting for?
No, don't deflate the balloon immediately. It has been one of the one instance that I told we deflated immediately, and that is when it happened to reflux back. We just, after the completion of this embolization, we just spoke a minute or two before we deflated it back.
So you're just waiting for it to solidify, and then you will deflate the balloon.
Exactly.
Okay.
If I may, since we are waiting especially for the young people, what we would do is, there is a very good IPS here, and the IPS is easy to enter. So we would go into the IPS and we would use long coils. If you use long coils, we end up using fewer coils. So that's what we would do. And if required, we would inject onyx from the venous side rather than from the arterial side.
So you were one of those 3 people who chose transvenous.
Actually, I hadn't entered it at that time, but I would have, because there's a very good, very big IPS in the inferior petrosal sinus. Going through the superior ophthalmic vein would be difficult because it is far more tortuous. But the IPS here is quite big and it should be easy. Because many times you can get a 6F guiding catheter into such a big IPS.
Rajiv, any thoughts? Balloon and coil? Yeah, okay. So you are conservative like me. So there is a question like, what's your target? When do you decide to stop? Look, how do you know the fistula is closed now?
Take an intermittent check angiogram after, and we deflate it just to make sure, and while deflating, we do make sure there's no movement in the embolic material. Yeah. Especially trickling towards the parent. Now we're taking it control.
Yeah, hyperglide is definitely onyx compatible. So yeah, so it's still filling.
We'll repeat another.
You're relatively safe, less chance of the onyx coming into, because it's a high flow outside, centrifugal, not centripetal.
Yeah,
so in that sense you are relatively safe because it's a high flow outside.
No, he looks very calm and composed. I would have been like very nervous doing all this. So
obviously he has done a lot of these cases.
Yes. It's just one of the other ways to do it. So like the whole idea for him, and I only requested him to show this technique because I don't do it, and as we could see from the poll, not many of us do it, and he has been doing this successfully for past so many years. So it's a good armamentarium sort of to have if you have a patient who has a big fistula, maybe not so affordable, or so maybe that's the case to start with, and we can learn the tips and tricks from Arvind as he's doing it.
So there was one person mentioning flow diverter as a treatment for direct CCFs. I think the idea is not bad, and there was a paper, I think 2 years ago, that mentioned a stage treatment. So first implantation of flow diverters, downstaging of the fistula, and then potentially going transvenously. I would like to know your opinion on that.
So I think, Stephen, you are going to talk about that later in the day.
It's an option,
No.
but we only used it for indirect fistulas. So
Yes.
Even if you have a flow diverter, you would still need a balloon to protect the ICA
sure.
when you inject it from the venous side.
No, but
So this
I
paper-
think in a direct CCF, we will not like to use a flow diverter here. So, not even as a last measure, I will not suggest. But like in an indirect CCF, again, like we will like to hear. I think Stephen has some experience which he will share with us. So, there is a question for you, Arvind. There are a couple of questions which are now worried that. Are you not worried about catheter getting stuck in your onyx cast? Like you have been waiting now for some time, 13 minutes almost. Have you ever experienced a glued catheter where you are not able to pull out the catheter?
That incident has never happened.
Okay.
You can easily pull it out.
Because when we do AVMs, we do encounter these situations that, if it has been there for some long period of time, it gets stuck. So you do not see that while you do a CCF.
No.
And what's your maximum time? Like how long have you ever done this? Like how long the catheter has been in that cast?
It has gone beyond 1 hour also, sometimes.
Oh, okay. So the balloon is still inflated?
Yeah.
Okay.
In between I had deflated it.
Okay, so there are a lot of questions. So you people also have an iPad. I don't know if you want to answer these questions on that. And heparinization is a standard heparinization, or you give a lot of extra heparin to these patients since you have a long occlusion with the balloon?
Following the standard heparinization after balloon infusion, that's what we routinely do. 5,000 followed by 5,000 after balloon.
And have you ever seen recanalization in these patients? Like
No, none so.
none. And do we have a denominator like none out of so many?
The denominator will be around 20.
Okay. So Anil is making a comment that if you have to use a flow diverter, I can't see him though, that it's better to put coils inside and then put a flow diverter. But then my argument will be, if you're putting coils, why not just coil it off completely, and why to even then give antiplatelets and flow diverter? Take a mic. Can we give a mic, please?
We have a few where we just do a targeted coiling, especially when you're going from the arterial side. Immediately at the point of fistula, just beyond the point of fistula, put in a few coils and then put a flow diverter. It seems to work well. So you don't have to really pack the whole sinus with coils. Just a few coils and then a flow diverter, because your coils are like the coils are exactly at the place where the fistula is communicating with the venous side. So that seems to work quite okay, though may not be every time, but yeah, you can get away instead of putting a lot of coils. So more recently, or at least I would say in the last few years, we started with this, but only difference was we used to inject from the venous side.
Yeah, that's what somebody asked. That's you only. All right.
Yeah, I used to inject from the venous side before.
So we have now two options. So we can follow the cheaper option of Arvind, where he's trying to save cost, or we can use Anil's option of adding a flow diverter and making it even more expensive.
Yeah, so you put up, okay, now if you look at these measures, right, as I said, we have, I have a few of such cases.
Yeah.
If you look at their follow-up MRs, you will see that it's not a reconstructed artery. The artery will be like, if you look at the MR, they will be all irregular, and you will see excavations over there, which means that actually you're not reconstructing the vessel. We are creating means we are sealing it, yes, but it looks very ugly and irregular. So that's why we started moving on from this approach to using a flow diverter. Because when you use a flow diverter, you actually get it very clean and nice. Like you don't see any irregularity. So I think in the long term, probably that could be a decent option. But of course, cost becomes quite big if you add in a flow diverter over the, no doubt.
Sure. Okay, so what are we doing, Arvind, now? We are still waiting with the balloon deflated? Now the balloon is still up, so... So can you just describe what are you doing? Are you like over?
I'm deflating the balloon.
You are deflating the balloon right now. And then we're going to do a test shoot.
Yeah.
So, Dr. Bogal, we do not have these memory coils here. So that's not an option for us. Again, I can't see you in the audience, but... So Arvind, have you ever experienced any cranial nerve palsy, like any of your patients have a...
No, none of the patients had cranial nerve palsy, except for that incident where there was a distal migration of the onyx, and without any clinical complications as such. Okay. Because onyx, when compared to blue, it is less thrombotic.
And
that we have observed.
And you always inject through arterial side and never through venous side?
Yeah. The venous side only when it is a indirect CCF.
But if it's an arterial side is there, you will go with the arterial side.
Yeah, if it's direct, it's only arterial.
And never in any instance in your experience where balloon got stuck, like balloon is stuck to the artery?
No.
Okay, we are getting there. So, Arvind, what we're gonna do, I think while you are injecting more of this onyx, Mumbai, we have to go to Mumbai now. And we will come back to you and give us some time. So, because KEM is ready and they will finish deployment if we do not reach on time. So we're gonna switch to KEM now. Okay, so for the second case in Mumbai, so this is a patient. In the schedule it's Vellore, but they are ready, so we are just skipping it. We'll come back to them. So it's 29-year-old male. He had a history of head injury at a workplace, no history of loss of consciousness, no motor deficits, and then while during the evaluation they found this left MCA fusiform aneurysm. And the first question, which because of the history we need to check, is how many of you will feel, is it a dissecting aneurysm, it's a traumatic, it's a fusiform, or you think it may be a mycotic aneurysm? We will do a workup for that. Okay. So 15 days, some small trauma, no deficits, no swelling, no evidence of any SDH or SAH. I think it's an incidental finding, and it's difficult to say one way or the other without, I think, a vessel wall imaging to support. But just by looking at the morphology, majority is, what do the panel feel? Panel is not voting. Sir, Dr. VP Singh, sir.
a fusiform dye.
Yeah. I think so too. I don't know. Professor Yong,
Yes.
fusiform?
Yeah, I think it's a fusiform aneurysm because normally the traumatic dissection is not occur in this MCA. So I would say this is a fusiform aneurysm. Okay.
And how do we treat them? Like, next question, please. So, what should we do? Should we do a braided stent? Should we do flow diverter? Do you think one is enough, or we need to telescope? Should we do a bypass or a coil?
Dr. Gaurav, can you ask him whether they have done vessel wall imaging in this particular case?
No, they have not done. I asked them.
Yeah.
They have not done the vessel wall imaging.
Yeah.
So that's why I said, like, we do not have conclusive evidence one way or the other.
Yeah. Okay.
I can't hear you without a mic.
Not doing anything also should be an option, right?
Not doing anything should also be an option. Sorry, we missed on that part. So not doing anything, so that's also an option. We'll always like to do something, so that's an issue. Just a show of hand, maybe. Who will not do anything? Okay, few. Okay, all right. Okay, so
I think it should not be not doing anything. It should be an active surveillance still.
I understand. I understand the part. Like, so routine, regular follow up. Maybe do a vessel wall imaging, see if it's increasing. We understand that. So overwhelming flow diverter. Okay. So can we go to the slides? Next slide. No. Hardware. Yeah. So he is planning to use a flow diverter. This is the hardware, and we can go to Mumbai now. Hi, Nitin.
Hi.
So
I was just overhearing the discussions. I think so. I don't know what was the conclusion. Many of them opted not to do anything, or
no. So that's an option. That's an option. Overwhelming majority is with flow diverter or a stent.
Okay.
But actually, I think it's a smart idea. Maybe just to follow up. Also, it's not a bad option. So that's what we were just discussing. But
so having said so, we have already decided to go ahead with the flow diverter. So this is a young male already discussed, I guess, 29 years old, had a trauma 1 month back, and this obviously is incidentally detected. But he has a big bump on the forehead because he was hit by some crane while he was at the workplace. Having said so, we have taken the axis, and am I audible?
Yes, we can hear you completely. We can see you also, actually.
So the hardware which has been discussed already, that axis has been taken, neuron max, then neuro, instead of neurobrace, it's a neuron 110, and we have taken a 027 phenom, and I'm just showing you now the roadmap. We have crossed the aneurysm, and this is the 427 parked in the larger branch of MCA. There is a bifurcation, rather trifurcation. One branch is arising from the aneurysm, and the other two are distal to the aneurysm, and still there is an ectatic vessel at the bifurcation of the two vessels branches which are distally. So out of that larger one, we have cannulated with 027. I hope you can see here.
Yes, we can.
Okay. So with the measurements and all, we have decided to use 430 flow diverter.
430?
Yeah.
Nitin, what are the sizes of the artery?
So can you...
So, Nitin, can you hear? Dr. Alurkar wants
measurements
of the. So, what's the diameter of the artery? Because it doesn't look like a 4 millimeter artery. It looks like
Yeah,
1.5 2
so
millimeter.
basically, can you just show the diameters? One second, I'm just showing you the diameters so that you'll get an idea. Yeah, so
He also has access to a biplane lab. Huh?
So number of biplane in India has grown dramatically in last few years. So yeah, so we can see the 3D, but you may have to actually read the measurements.
I'm just rotating the screen.
You can just say it out. It's fine.
Okay. Are you able to see?
Yeah, but you know,
Not really. You can read
we
out
won't
the
be able to
measurements.
read out the measurements, Nitin. Like, yeah, we can see that the length is coming like 20.77, and then it.
So that's a divided.
Yeah.
length.
Now we can see. Now we can see.
Ideally, you can see the added length is totally 33,
Ah.
as well as the diameter of the proximal vessel is almost 3.4 something. So to cover the aneurysm, which is quite a large, and if you think it would be prolapsing in the sac, so we decided to take a really large one, considering the proximal M1.
But, you know, honestly, I feel like just by eyeballing, it doesn't look like a 3.5 millimeter artery to me. Like,
just show the diameter.
No, we can see the diameter, but sometimes, you know, the calibrations may not be accurate. I agree with what you are saying that in the fusiform segment, you're going to lose a lot of length and the diameter will be much bigger there. That definitely looks like a 6 or 7 there.
Yeah. So we have decided like we'll take a 430.
Yeah.
And I will just, we have crossed and just will going to deploy now.
Okay. All right. So we can go to your screen now. We can get rid of the measurements screen. So panel, any view on the sizing? We're all taking deep breaths, Nitin. We are just hoping it will fall right.
So this is the 430 Derivo.
Okay. Is it a heel one or it's a plain one?
Plain one.
Plain one. Okay. So there is a concern whether you think this might elongate too much.
Yeah.
And I can
let us see.
Let us see. Okay, that's a good answer. Let us see how it goes. And maybe a panel can answer Anil's question, like, do we have any literature on the natural history of such incidentally detected fusiform aneurysms? Because ISUIA actually didn't cover such aneurysms. And I think it's a very good question. I actually do not know what's the natural history of these aneurysms. Professor Piero, you want to?
Can you repeat the question, please?
So the question is, do we know the natural history of such fusiform aneurysms? Our previous ISUAIA trial of unruptured aneurysms do not cover those fusiform MCA aneurysms. So how do we know how these aneurysms will behave, like if left untreated?
Yeah, we don't really know, you know. We have there was this interesting paper published by Istvan Zikora, but dedicated to fusiform aneurysm of the basilar artery. And you know, he had 2 or 3 cases. The 3 patients died, and he had anatomopathological examination. and it was showing that at least in the basilar artery, it was not working. It means that the flow diverter was in place in the fusiform aneurysm, but there was no thrombosis around the flow diverter because, by the way, the flow diverter was not applied against the aneurysm wall. But okay, it was reported in basilar artery aneurysm, and probably it's not the same pathology. Probably it's atherosclerotic aneurysm, and maybe it's a reason why it's not working there. I am not sure that it's true for MCA aneurysm.
Yeah. Professor Yong?
Actually, normally this MCA is totally different from basilar VB dissection, so relatively very benign. So actually, this is if I do treat this patient, actually I just do a little bit follow up, just 3 months or 6 months, and then if there's any change, I'm able to treat this patient. So we'll see.
Okay, Nitin, can you just describe what's happening?
Yeah, so I'm just taking the derivo up. Now we're just out of the neuron, and I'm just advancing it to the petrous and cavernous cause. I'm feeling a little resistance here to cross to the supracrinoid segment.
This is the Phenom microcatheter, right?
Yeah, yeah.
Okay.
Phenom 27.
And you expect it to land in M1 or just the proximal M2?
Yeah, land in M1, maybe a little distal to the bifurcation of IC.
So I'll let you push this, and I'll let the panel answer a few of the questions. Actually,
Sure.
you can see it on your iPads. You don't need to turn around. So if it's possible for you to do that. So there's a concern like we are jailing 2 branches with the FDA. So are you worried about jailing that, or we are okay? So I think more and more as we have started doing distal flow diversion, we are not really worried about jailing these branches. So because we have realized that even if they go off, the collaterals take over. So whether we are treating MCA bifurcations or ACOMs, we are like in our own experience, we do not worry about jailing the branches. And I think in this particular setup, it may not be a bad choice to jail it. So
we don't have an option, definitely.
Anybody from panel disagrees or have a different view?
So
You have?
So I would definitely agree to your opinion.
Mic. Can we give a mic, please? Can we get a mic here, please? Okay. So you are finding resistance in pushing the device?
Yeah, well, it's a large device, definitely there will be some resistance, but I think so I'm there.
Is it possible for your cameraman also to show the native image side by side along with the roadmap image?
Can you focus on the...
Yeah. So, like, if we can see native and your roadmap side by side. Yeah, but the lateral probably. Lateral is better than the AP here. No, the lateral, the below one.
This one. Can you see now?
Yeah. I think the device is better seen here. Can we have simultaneous, like one picture at roadmap and one of the native?
So can you just show this?
Side by side, both the pictures. Yeah. Probably this is better view. This is a better view. Yeah.
So
So your wire, is it poking the branch now?
yeah, it's just taking the branch and going distally definitely. Okay. So my plan is to start deploying from this area what I am seeing the FD. So I'm going to withdraw the micro a little bit. Releasing the tension in the micro. Advancing the FD a little bit so that the micro comes back.
Yeah. So we could have used a braided stent, as the question said. Like that was one of the options of placing braided stents. So that's a choice which we have. And for the clot, I think if the clot develops, we can give abciximab, tirofiban, integralin. So I think that's
I think so. I'm going to start opening from here.
Yeah.
A little distal purchase I've taken because I have a long segment there. I'm just concerned about its expansion into the parent aneurysm because it's quite a bigger one. So the way of opening up the derivo, as you can see here, is just push it. There's no need to push. As far as opening up very nicely. There was a little resistance while I was taking it up to the M2. But once I crossed the bifurcation, there was no problem. And I'm just pushing it and it's just opening very smoothly. Advantage is that it is seen very well. I hope you are able to see.
Yeah, we are able to see the deployment. So I guess you are unsheathing it at this point.
Yeah. So now I'm unsheathing. I'm at the aneurysm segment. This is what is going to be a huge discrepancy in the size and disproportionate opening of distal as well as proximal. And that's why I took a larger size.
So anyone in the panel would have used a telescoping FD or maybe a braided stent first and then FD later on? No? Same thing? Okay. Anyone in the audience for telescoping FD or deploying a Leo first to get a braid and then deploying the flow diverter in that?
problem if you do that, sorry.
Yeah, Rajiv.
The wire.
So Nitin, we are concerned about your distal wire. So are you? I hope it's in the lumen and not perforating.
Yeah. So definitely in the A plane, it is in the lumen.
Okay. It's slightly more distal, and at least in the I don't know, in the roadmap there's a doubt, but just keep a watch on it.
Yeah. So it has taken the loop of the M3 and it has gone into the M3 branch of this larger branch of the M2.
Yeah.
So I'm just at the distal or mid M1 now, and I'm just going to push it, and I hope it doesn't fall there into the aneurysm.
He also is seeing the AP, which we are not seeing, so that's also a difference here.
It's a shot.
How many feel it's gonna fall short?
Yeah.
A lot of people feel here that it's gonna fall short.
So that's what I was just thinking, whether I get it back. Now we know that the behavior of this, I'm just thinking I'm getting it a little behind.
Yeah. So that's a thought. Like you have started deploying it, you deploy it 70-80%, you feel it may fall short, you can resheath, recapture, and maybe come back with your distal landing zone, and then hope that it's gonna go fine. In my experience, sometimes when there's discrepancy in the diameter, sometimes resheathing becomes difficult, especially if it has expanded completely into the fusiform segment. But here, I think you had no issues. So you're gonna resheath totally, right?
Yeah. So I'm just getting it back now.
Okay.
I've got a little back, but maybe a little more. Yeah, that's perfect, I guess. And I'm going to start deploying again from here. So that is the advantage. You're able to see the FD very well, and you can resheath, and let me just tap it a little bit into the aneurysm so that proximally I'm not landing in the ICU.
Okay. Any questions, any suggestions, comments? Yes, please go ahead.
So I would be interested in why you would choose a Phenom 27. I would like the same microcatheter for that one, but I would be interested in his opinion.
Okay. Nitin, any thoughts on why Phenom 27 only?
Phenom, or I mean 27, or I was talking about smaller size?
I'm asking, I mean, you could also use the Neuroslider or some other 27 microcatheter. Why the Phenom?
Yeah, so basically, I was thinking it a little stiff when we are entering the aneurysm for this case, the Neuroslider. So I'm a little pally with Phenoms nowadays, and it's a really better one as compared to slider, definitely.
Okay, I think now you look in control for your proximal landing zone.
Yes.
So you're still pushing or just unsheathing now?
Now unsheathing, I just pushed a little bit, but I'm just unsheathing now. And I think so I'm going to land at what I wanted to, where I planned to, that is at the mid M1.
Dr. Gaurav, do you feel this time it is not expanded? Yeah, I'm here.
Yes.
This time it is not very much expanded in the aneurysm.
Yes, because he has not pushed a lot. Yeah, this time he has just unsheathed.
Yeah, this is unsheathing. And this is good actually.
So when we resheath, maybe the device will behave a little different than the first time, and it may not expand as well as. So because of the behavior and how you unsheath, I just want to land it a little proximally so that it doesn't fall back or it's not short. So I was going a little slow and covering the M1 and not landing in the IC. So I'm just pushing it. I tried to stack a little bit, but I think so I've covered well.
No, it seems stretched proximally.
Sorry?
The device seems stretched in the proximal part.
No, because Ajay, we are seeing only the native images.
Yes.
I think the caliber of the artery there is 1.7, 1.8.
Yes.
It's a 4 millimeter device. So that's how it will also look like that way. So do you plan to recross and massage the device once you have deployed it? That also may help to settle it up.
Let me just check the deployment. Once I'm done that, then after the shoot, we'll decide.
Okay.
I believe we must avoid this maneuver in this particular case because we are having a fusiform aneurysm and that might create problem while crossing that aneurysm part.
But if the device
yeah.
if the device looks a little bit not so well opposed to the wall, what will be your strategy then?
We'll see.
Okay. I think that's the most common answer today.
Yeah. But it'll open. It'll foreshorten.
No, I think it should. It should. Anybody, Dr. Alurkar, any comments?
Probably I would have gone with a smaller diameter. But really worry about instant stenosis since there is a good mismatch between the diameter of the vessel and the stent.
Smaller in terms of diameter or length?
Pardon?
Small diameter, yeah.
So and be ready for telescopic stent if required. The side branches are going to be compromised over a period of time, and the branch in which we have deployed the FT is going to take over the collaterals. So if there is a stenosis in that branch itself, it could be a problem.
So I think a very valid point. Whenever you increase the, whenever you change, there's a discrepancy in diameter too much. At a certain point, the flow diversion property will increase dramatically.
So I've deployed the device. It's well open.
Oh, okay, yeah, wonderful.
Can we zoom the AP also?
Can we AP roadmap? Can we zoom that, please?
Can you just show the AP?
Yeah, and you are recross. Okay, and you are planning to recross, right?
I'm just going to take a shoot now.
Okay.
And then plan the next strategy, depending on the device behavior and the coverage of the aneurysm.
So I think we covered that question, whether we can just use a braided stent. That I think is a very valid choice. And as Stephen was also asking whether you feel phenom, you are asking about phenom for a particular reason.
So yes, in my opinion, to unsheet and resheet the Derivo, the Phenom 27 is the perfect microcatheter. In such scenarios, the neuroslider, in my experience, is too stiff, and resheeting can be problematic. But the Phenom kind of brings the optimal trade-off.
So what's your choice of microcatheter?
I'll take the Phenom 27.
Okay.
Okay.
So are you happy, Nitin?
Same is my opinion. As you said, definitely neuroslider 27 is a stiffer catheter, and definitely opening and resheeting, I don't think so. That's more of a problem, but the stiffness is a concern all the time, especially when we are entering such a M3, M2 and M3.
Okay, so Nitin,
now here there is a little stasis in the superior branch.
Yeah.
Or the M2, the branch which has been covered. So we just jacking up the blood pressure and.
So what we're gonna do, Nitin, while you are assessing this patient, we're gonna switch to the next center and we're gonna come back to you. Okay.
Definitely.
All right, and then, all right. Thank you so much, and we'll come back to you. And can we show the third live case now? Vellore. We go to Vellore. So this is the case. This is our next case. Can we have it on the screen? Okay. So CMC Vellore, and again, that's the history. But in nutshell, it's an incidentally detected aneurysm on evaluation for a headache. And it's a very interesting aneurysm. It's on the inferior division of the right MCA. It measures something around 4.5 millimeter, wide neck, broad neck, and there is a trifurcation involved there for the MCA. So the first thing is, since it's a 4.5 millimeter incidentally detected aneurysm, will you treat this aneurysm? Yes, no, can't say. How many from the panel will treat this aneurysm? Stephen, you will?
Yeah, definitely.
Professor Young?
I'm going to treat, yeah.
Okay, so is panel influencing your vote? Like it's switching from no to yes? All right. So I think most of us wants to treat this aneurysm. And if we do have to treat, what's your preferred option here? I may be missing out on a few, but we go for clipping? We have few surgeons in the house. Do we do balloons, stent, flow diverter? Do we do intrasaccular here? So that's, I think this view describes the best anatomy, like it's a broad neck, irregular lobulated on one of the inferior division. Okay. Interesting to see intrasaccular. I would have thought it's quite at an angle which is difficult to hook and deploy an intrasaccular device here. What do you feel, Dr. Alokare?
I agree with you. You know, I think when it's not really centered on the bifurcation, but it's on one branch of the bifurcation, it's relatively difficult to properly place a intrasaccular device, whatever the kind of device you use, web or contour. But so,
what will be your choice here?
In this case, I think we have two options, which are stent-assisted coiling or flow diverter in the branch where the aneurysm is. Personally, I will probably choose flow diverter.
Okay. So, anybody who will not use a flow diverter will do clipping or stent coil?
Yeah, I think I want to say the clipping, we can provide straightforward to treatment. But,
Okay.
If you don't like a crack the skull, I think the second option going to be stent-assisted coiling. The last option going to be the flow diverter, not intersacral devices.
Okay. So, the team at Vellore is planning to do a stent coil. That's the hardware which they are planning to use today. So, plan is to do within the Atlas and coils. Can we go to Vellore now? Hello. Hello.
Good afternoon, Dr. Kaur.
Good afternoon. Sorry for the delay. We have to bump you for Mumbai.
Am I audible?
Yes, you are very much audible. We have seen the pictures, and I don't know if you were hearing the discussion.
Yes, we had the discussion.
So,
and this question, we also have questions to discussion. And whether to click and more people are interested for clicking.
Your voice is a bit muffled. Hello.
Some corrections audible.
You are audible, but your voice is a bit muffled.
Was there a proximal stenosis? I wanted to ask a question.
Yes. Yes, Chandrajit.
Yeah, was there a proximal stenosis there in the imaging?
Dr. Sham, do you think
there appears to be some narrowing? There appears to be minor narrowing.
Yeah.
But we did not think that is a significant stenosis to be considered.
Okay. So where are we now in terms of have the microcatheters in place?
Yes. We are trying to cross the aneurysmal segment. And it's a very acute turn, as you can see here.
We can see you, but we can't see your pictures. Like we need to see the planes.
Okay.
Maybe cameraman can focus on the yeah. Now we can see it. It's too zoomed.
All right. Are you able to see now?
Yeah, we are able to see. If you can describe, we are able to see a
Yeah, what
roadmap.
we have done so far.
Yeah.
What you have done so far, we'll share with you. We have taken the axis and we have taken the microcatheter and we are trying to cross the segment which has got aneurysm, which is a very acute term, and we have been trying for some time, maybe for nearly half an hour. So far we are not able to cross.
So you are not able to go into that division.
Yeah, we are not able to get it. So what we have done is we tried with the acute curve on the wire.
Okay.
Pro, and we also have used axis, and we also have made a loop within the aneurysm, and then we are trying to go distally. And we will keep trying for some more time.
Okay.
And then get back to you.
Is your catheter? Where is your catheter right now? Is it in the aneurysm or in the M1? The tip seems
it's very close to the aneurysm.
It's very close to the aneurysm. So I think
yeah.
What we can do is we can let you try this, and once you have crossed or you are ready, we can come back to you.
Okay. Yeah, that will be fine.
All right. Okay. All right. Thank you. Can we go back to Nimhan's place now again?
Of the module.
Hi, Arvind, we are back. Can you hear us? Hello?
I can talk. They can hear us.
Arvind, can you hear us?
We can hear you, sir.
So, where are we? Are you done with the case?
Almost.
How much onyx we have injected till now?
This is after injecting 2.5 vials of onyx.
Okay.
This is the most recent run.
Okay, a little trickle.
We complete the embolization with one more bolus injection.
Okay. So you plan to inject more, or you just plan to wait to see if it thromboses on its own?
We have injected a little more following this injection. Now we are taking a check run with this sample open.
Okay. And there was a question like, do you give steroids after this? Okay, there's a little bit of flame.
No, we don't give steroids directly.
But usually we put the patient on ecosprin.
Okay.
Because anyway it will be sealing the red, so it may be a little bit thrombogenic. That's why for a month we put the patient on ecosprin.
All right. So do you plan to inject more onyx here?
Yeah, we will continue doing so.
Okay, so then we're gonna come back to you again while you do this. Any questions for Dr. Arvind? Okay, we'll come back to you. So can we go to Mumbai again?
Gaurav? Yeah, I wanted to add something. You asked a question regarding whether we have gone through venous side or not.
Yeah, so Chandrajit, can you just introduce? So he's from Nimhan's.
I'm from Nimhan's. I'm from neuroradiology department there. I'm a professor there. Okay. So the thing is, I have done a case in which obviously when the sac is too large, and as you know the financial implication of it. So what I did in that case is I went through the venous side and I injected the high concentration glue through the venous side. So that my idea was to make the sac small. So that there are two things. One is that when I put the coil subsequently through the arterial side, the number of coils required will be less, and obviously the back-end density will be much better. So that was the idea, and I think we have done a couple of cases like that, just to reduce the volume of the sac, and maybe we can do it in a way which is economical.
It's interesting idea, very interesting, to put the glue to reduce the size of the sac and then coil. Okay, this is the first time I've heard this, which is interesting, very interesting. Thank you. So, are we ready with the Mumbai thing? Yeah. Nitin, can you hear us? Dr. Nitin? Can we check with the AV team? Are they able to hear us? I think...
Please, sir, hai nahi.
Okay, all right. I think they are doing a Dyna CT there, and their microcatheter and everything is out. So what we're gonna do is we're gonna end this session. We're gonna have these final pictures in the next session. As I said, it may not be possible to finish all the cases completely in one session. So I close this session, and we will move on to the next session, and we start from there. Okay? But don't go anywhere. Thank you so much. Thank you, panelists.
That was quite a remarkable session indeed. Can we thank our panelists for curating it henceforth? Can we have a round of applause for them, please? Moving on to our second session of the day, I would request the humble presence of our moderator, Anil Karapurkar and Mark Rebo, to kindly join us here on the dais. Let's welcome them with a round of applause, please. Followed by our panelist henceforth, Dr. Gaurav Goel, Anil Gopinathan, Khairul Azmi Abdul Qadir, and last but not the least, Yosoki Inu. Let's welcome them with a round of applause. As we move forward to our next session now, I would request humbly to our moderators to kindly join us here on stage. Let's welcome Anil Karapurkar and Mark Rebo with a round of applause, followed by our panelists henceforth, Dr. Gaurav Goel, Anil Gopinathan, Khairul Azmi Qadir, and last but not the least, one more time, Yosoki Inu. So let's welcome them with a round of applause, please. And I assure you our next session is going to be very interesting.
Okay, so Dr. Karapurkar is just joining us. Dr. Mark Rebo is in the hall. Anju, can... So while we are waiting for our next moderator, I'll just do the makeshift moderation till they arrive. So we are ready with Austria? Okay, perfect. Okay, so welcome panelists. I'm just going to join you as soon as Dr. Karapurkar and Dr. Mark Rebo comes. So the next case, we're going to go to Coimbatore to Dr. Matthew Cherian, and he is going to tell the history. I do not have the history of this patient, but these are the images. So we can see a dural AV fistula and supplied by both middle meningeal and occipital artery. So the plan here, of course, is embolization using a liquid embolic. So that's the plan which we have using Headway Duo, Minox 18. And he is planning to do a pressure cooker, which I think he's going to explain it to us. So I'm just going to skip this. So that's the hardware which we will be using for this case. And we can go to Coimbatore now. Okay. Maybe we are... Dr. Matthew?
I can hear you. Can you hear me?
Yes, we can hear you. I'm Gaurav here.
Yeah, hi Gaurav.
Yes.
Okay, can you see us also?
Yes, we can see you.
Actually, we had sent the case history to you. One of my residents will just present it to you. So, like you saw that this is a dural AVF, predominantly coming into the trochlear with a very poor venous outflow and retrogradely filling the superior sagittal sinus and the cortical veins. And so we we are going to enter the middle meningeal artery and use this as a primary access. So we'll also demonstrate a kind of a technique we use very often to rapidly push the liquid embolic. Here we are going to use Minox. Minox is basically an Indian version of onyx core squid. And so what we're going to do is we are going to take one microcatheter, the sonic, as distal as we can in the feeding artery, and we're going to keep a headway duos proximal to that. And when we start injecting Minox, and as soon as a little bit of reflux starts, to the second catheter we'll be injecting NBCA at somewhere in the dilution of 50% to form a plug which will be kind of solidifies really fast. And that plug allows us to actually prevent the reflux of the liquid embolic further, and saves that time that we spend, waiting for the reflux to stop and solidify. Okay, so that's the plan that we have this afternoon for you all. And we thought, we could actually do it without it, but we thought we'll just show it. It's a very simple and a very easy way to create a pressure cooker effect without having to push the coils and then gluing it. That was the way that Rene had initially shown it to us. So we've been kind of doing this quite often. So we have the guiding catheter in the external artery. It's Envoy, and we are taking 2 micros. One of them is in the maxillary artery. We're going to take the second one now. And when we have both in, we'll just move to the lateral plane. Okay. So I don't know what you can see on the screen, but
we can see the RHV and you pushing the microcatheter, and on the so now that's an inset, and we can see your lateral plane.
Did I chip the wire? Just push the wire out, please. Okay, 1 second. I'll just come to it. Yeah, it's okay. Pull back. Just a sec. Yeah, okay. We are just sort of. Actually, since we have got materials free, we got the luxury of having a second detachable microcatheter, which is not so important in the meningeal vessel. We can also even work with any catheter which is even used for coiling to inject glue. But Gaurav, your show has drawn a lot of attention, and we've been getting calls from all the companies telling us, can you please use my material? So we are fortunate we got a lot of good stuff available in the lab, all for nice.
Okay. Thank you for your nice words. So, okay, so what's the wire here?
So what you see over here is actually the Duos catheter with access wire. Like I said, what we're going to do is we're going to demonstrate how we use NBCA to form a plug. So I'm just taking the second micro, which is sonic. Now, like I said, it's not mandatory you need a detachable catheter, but if you can, this. Okay, this is the second catheter in the meningeal. This is the. Are you able to see the screen?
Yes, we are able to see the AP view. We are able to see your 2 microcatheters.
So we can see the second wire.
Yeah, we can.
Yeah. So I'm going to go to a straight lateral after this. It's easier to understand the anatomy there, but right now, so we got 2 catheters. Right now I'm doing the Duos, and the multiple dots obviously is the detachable. Okay. Yeah, let's just go to a lateral for the time.
Now we are seeing both the planes and we are seeing your hands. Now it's a perfect view for us.
Okay, fine. We're just going to show you on the lateral plane. Be a little more easier to understand what's going on. Just 1 second. Okay. I'll just do a small thing. Don't like the wires when they take the roadmap. It sort of clutters the image afterwards.
Okay.
Just pull the wires down. We know we got 2 micros, and we're just going to take an injection. Huh?
Dr. Karpurkar sir, you want to add something?
Yeah, there's many ways we can create the pressure cooker plugging. Sometimes this vessel is quite small to navigate to catheter.
Sorry, I think they
so sometimes we just use for plugging purposes we use fill first because fill will harden faster than rather than penetrate with more liquid like squid 12 to complete the job.
Yeah, but the fill is unfortunately not available in India. We do not have access to fill. It was introduced and then withdrawn.
Okay, it's a very good liquid embolic material for plugging.
Dr. Matthew, can we do one thing while you are putting your microcatheters? Can we just move on to Austria and come back to you in 10 minutes as you have placing the catheters?
Yeah. When you are at Austria, just tell him that I'm coming there also.
Okay.
For a holiday.
We'll do that. I'll pass this to Dr. Monica for sure.
So, yeah, okay. Yeah, please carry on and join us back a little later.
Thank you so much.
Yeah.
So now we're going to move across the globe and go to Austria, where Dr. Matthew is going to go for vacation next month. But right now we have Dr. Monica Killer there. Can you hear us?
Hello, this is Austria, this is Salzburg calling. My name is Johannes Pfaff, I'm the head of the Department of Neuroradiology. I'm here with my colleague, Frau Professor Killer-Oberpfalzer. She's already standing at the table and already inserted her catheters to treat MCA bifurcation aneurysm on the right side. We have a 60-year-old patient with an incidental medial bifurcation aneurysm on the right side, with a base of approximately 4.5 millimeters and a height of almost 4 millimeters. And from catheter-wise, we have 8 French Asahi Fukuki guiding catheter already in place, and 5 French Sophia with 115 centimeter as an intermediate catheter, and headway 21 microcatheter, and an Asahi guiding wire to insert the microcatheter into the aneurysm. And we are already there, as you can see. We are about to plan to implant a contour device.
And have we decided on the size of the contour device there?
Yes. We had to, there are several device diameters. There's the 5, 7, 9, 11, and 14. And because of the size, we decided to implant a 5 millimeter contour device. Maybe a 7, but we were a border between the 5 and the 7 millimeter diameter device, but we're starting with a 5 millimeter device.
Okay.
We're good to go. I'm giving thumbs up, and we're taking the device out of the pocket and now inserting it to the patient. Just give us a few seconds. Frau Professor Kieler-Oberfalter, she's on the left side. She's now taking the detachment wires. As you can see, she's already preparing for detaching the device once in place. And this is going to be detached electronically or electrolytically.
But we have still not placed the device, but you are preparing it in advance.
Yes, we prepared this in advance so that once we are in place and contour device fits, we will be able to detach it right away.
Any difference?
Your device that you use is exactly of the size of the aneurysm, or do you oversize it by 1 millimeter or undersize it by 1 millimeter?
So the aneurysm size is of course important as in all the cases. The width of the aneurysm is 4.8 millimeter, and the neck has a 3.5 millimeter range. So it's almost at the border between the 5 millimeter contour device and the 7 millimeter contour device.
And the neck, would you be, what is the neck here you said? The neck of the aneurysm.
Do we have the diameter of the neck of the aneurysm? Can you hear us? Do we have the audio? We lost the audio connection, I guess. We actually can't hear you. So that's the contour device, and it has to be withdrawn in. Typically, it needs to be dipped in saline. That's how we do it. We dip it in the saline and then withdraw it back. Can we pass a message to them that we can't hear them? I don't think they can hear us.
Okay, let's try again.
Can you hear us now?
I'm here. I'm still here. Do you hear me?
Yeah, we lost your audio in between. So we were just wondering what was the diameter of the neck of this aneurysm.
So do you still hear me? Maybe we just had technical problems with the connection. But Professor Kieler is now inserting the device to the microcatheter.
So we are running a poll here, and we were just wondering if we were not using contour, what we could have done. So the other option is, of course, FD or other intrasaccular like web. Balloon coil, I think, could have been difficult.
Yes. So stent-assisted coiling would be an option. Web would be an option. But in our department, we sort of left the web placement and moved towards the contour, as we have like the dome of the aneurysm, the tip of the aneurysm will not be touched by the contour device once it is in place, as opposed to a web. So that's more or less our philosophy at our department here. But of course, web would be an option as well.
Do you routinely pre-medicate your patient with antiplatelet in this case?
Asking about the antiplatelet regime for this.
Do you use antiplatelets? Is the patient on antiplatelets?
the patient was placed on dual antiplatelets 5 days ago, and every patient gets a herodine testing before he's placed on the OR table and before we intubate the patient.
And how long do you keep them on antiplatelets?
So the patient, once it is implanted, the patient will be kept on antiplatelets for dual antiplatelets for 3 weeks. Then he gets a dynasty control and to see whether there's already stasis within the aneurysm. And then we switch to mono, and after half a year, the patient is usually only continue to have aspirin as a monotherapy. However, now the device is implanted, now the device has been inserted into the aneurysm. You see that the first is whoops, now it's in, and you see that the shape is like too wide, and the radial park marker is already protruding into the vessel, which is a normal situation, because as with the web, the radial park marker is always showing into the vessel. So she's going to make a control whether there will be flow within the aneurysm and within the side branches.
Do you confirm these deployment by VASO-CT or Dyna-CTA?
So usually we do a Dyna-CT with contrast after implantation, and we do it as well a day after one. Monica Killer just gave me the thumbs up. She's happy with the position of the contour device. You can see that if you move through the run, you can see already a little bit of stasis within the aneurysm. And now Monica is coming out of the angio suite, and she can. Yes. Yes. And she's now saying that we're doing a Dyna-CTA to confirm position to show the vessel. So the patient is receiving a Dyna-CTA every day, the day after the OR, as a imaging before every control imaging, so before the patient leaves the hospital. And when the patient comes in, he usually gets a Dyna-CTA within 3 months, and then in 6 months, and then in 12 months.
So all your follow-ups are with this VASO-CT or Dyna-CT? No MRIs?
No MRIs, because the contour is like a Faraday cage, and you would need an R contrast, and you would need a longer exam. And you might not be sure whether the material of the contour would impair the imaging and would mimic still an inflow. So that's why we use Dyna-CT.
Okay. This looks perfectly placed. This looks perfectly placed. But in case if there's an accidental partial encroachment into one of the daughter's side vessels, is it a matter of concern? Not fully occluding, just partially encroaching one of the daughter branches?
Well, usually after implementation of the device, we wait for a minute. We wait if there is like thrombus building on the device, and whether there will be clot closing up any one of the side branches. But once as the patients are on dual antiplatelets, and when the device is implanted for like 20-25 minutes, it usually should not occlude afterwards. If the device, however, already with the implementation occludes a side branch, there's either the option to reposition the device before detection, of course, or to place a different stent into the side branch if you want to ensure that this will not be occluded.
So it means you regularly wait for 25 to 30 minutes after the device is deployed, right?
We usually wait for the after implantation just to make sure that there's no building of thrombus at the radio pack marker within the vessel. But we would do this same when we implanted web device, for example.
Okay. So what we're gonna do?
Just as a safety precaution.
I think you have another aneurysm to treat in the same patient. Are we treating?
So the patient has a MCA aneurysm on the other side as well.
Yeah.
However, this is differently shaped, and I'm not sure whether we are able to implant their contour device.
Okay, so this is the only one we are showing, right?
Okay. Yes, we will come back to you.
Okay. So what we're going to do while you are processing these DynaCTA images, we will just switch to another center and we'll come back to you in 10 minutes. Thank you so much. Can we go back to Nimans? They are done with the case, so we'll just go back there, see the final pictures. Yeah. So
So, Relive is done.
So Arvind, can you show us? Yeah, we can hear you. Can you show us the final run?
Final run is this. Yeah. Totally occluded.
Oh, I think it's beautiful. Beautiful, gorgeous. Absolutely gorgeous. So, top class. So, I think
in this procedure, what happened was, I think the catheter position was not correct. That's why it took so much of onyx. We have injected nearly 2.5 vials.
How many?
2.5 vials.
2.5 vials. Okay, not so bad still. It would have taken like at least 15 coils or something. So not so bad looking at this. So we are running behind time, Arvind. So thank you so much for sharing these pictures.
Thanks a lot.
Thank you. So over and out with you. So now we go to Vellore, and I think they have crossed. Remember this aneurysm? Yeah. Okay. Perfect. So we are moving back and forth. So, Dr. Sham, can you hear us? Okay. I think they are putting the atlas there. So they had some difficulty crossing, but they have been able to cross now. So that's the marker of the atlas stent which is coming there. Dr. Sham, we can barely hear you. If somebody can just answer on your behalf, somebody from your team.
Okay. Am I audible now?
It's very, not so audible. Like we can just barely hear you. Yeah, so the audio is not very clear.
Okay. We are going to deliver the stent now.
Okay.
We have taken
yeah, now we can hear you.
Yeah. We have taken the stent across.
Yeah.
And we have kept the other microcatheter J junction aneurysm. Shall we take the first loop of the microcoil? Yeah. Okay. Yeah, do that. So we're going to deploy the stent now.
Okay. So where is your proximal landing zone gonna be? In the division or in the M1?
It is in M1.
It's in the M1.
Proximal day is in the M1. We have to it has gone fully. So we can see the stent is significantly into the month. We are going to pull it back. Yeah, we're going to pull it back. No, the other marker is higher up. Yeah. Okay, yeah, you can start pulling.
So we have to keep a watch on the coiling microcatheter while we are
pulling
this back.
Yeah. Initially, we had a lot of difficulty to cross the aneurysm. Now, subsequently, when we put the second microcatheter, it was trying to follow the previous one. I think it's a buddy catheter. Yeah. I think this is fine. Yeah. You can come some more back to me. Yeah. So the other microcatheter will put the coil. We'll take a coil loop. Yeah, we'll wait here. Quickly get the coil, helical coil. We can come some more back. No? Yeah. Gaurav, what do you think about the position of the stent?
So panelists, what do you think of the position of the stent? I think it's fine. I think.
Okay. So we'll go and deploy now.
All right.
Yeah.
That might be better.
Any questions, comments? We can have the questions if there's any suggestions.
Yeah, no. I can pull it if you want. You ready? Keep going.
You deploy the stent fully and then coil the aneurysm.
Dr.
Okay, yeah. We have kept it jailed. Okay, fluorosafe, please. You get the point.
And Dr. Gaurav,
310.
can you ask,
310.
before opening the stent, do he believes in keeping few loops of the coil inside the aneurysm so that if it accidentally
it's a protection against the movement of the catheter.
Comes out, we can re-enter.
Yes. Yeah, we can hear you, Dr. Ajay.
Yeah, sir.
Yeah, that's a good suggestion. That's a good suggestion. Yeah. This catheter was not very stable, so we just wanted to deploy the stent.
Okay.
And other thing, what if you notice, if this aneurysm is from the convex portion of the artery, so in case if it comes out, we can just get it. Okay, you ready? Yeah.
Because the aneurysm is coming from the side wall, so entering might be an issue.
Yeah, if it comes out, it will be tricky to re-enter.
Yeah. Ready? Yeah. Ready? Feel good? So we may have to pull the microcatheter right down. Okay, go ahead. Ready? So we have taken a 3 mm 10 centimeter coil.
So it's a 3 by 10?
3 by 10, yeah. 3 by 10. Okay. We have gone to the level. I think. Yes. All right.
What is the coiling catheter we are using, sir?
I think it's an SL10.
SL10. So we'll pull it back a little bit. Yeah, it is in the system. I'm not 100% sure. Yeah. So after we deployed the stent, the morphology has changed. You can see that it's more straightened.
And your catheter is now jailed and fixed inside the aneurysm because of this stent.
Yeah. That's true.
Which coil is this? 3 by 10.
Dr. Sham, which coil is this?
Yes.
It's a target?
This. Ready?
I think it's a target coil, sir. I'm not so
Yeah,
sure.
it's a target coil.
It's a target coil.
Size of the coil, sir?
3 by 10.
3 mm, 10 centimeter.
3 by 10.
Do you plan to densely pack this aneurysm?
Some contrast ready? How much is the density we are getting? By this? Yeah. It looks like no loop has come inside the artery. That's fine. Okay. We'll take a check run now. Okay, ready? We'll take a run now. Ready? Yeah. Okay. Looks reasonably. Any comments from your side?
Looks good, sir.
Okay.
So can somebody take the point?
Yeah. So I think it's looking good. The stent is well in place, protecting it. You are well secured inside the aneurysm. The coil is in place. What we're gonna do in interest of time, we will let you coil this, and we're gonna switch between the two centers, and we'll come back to you. So Coimbatore is ready. We're gonna move to Coimbatore now.
Ready?
Dr. Matthew, we are back. Sorry to keep you waiting.
This is why I say all this. No, I just find it crazy. At the end of the day, it is like some circus. See, at least when
we can hear you.
Santosh does just one case, one center, you keep on doing it so that it's over. How slow it is. You see what's happening. This is.
Dr. Matthew, we can hear you. I know you are not happy. Come back.
Wondering when.
Sorry to keep you waiting. I know you are not happy.
Sorry, I was just saying that the patient's intubated and
we understand.
Inside catheters in the brain and we are waiting. So
I'm sorry. We apologize.
I always get worried,
We are there. I can see you have microcatheters in place. So, are we ready to start?
Yeah, I'm ready to start. We are waiting for you. That's all.
You are live on the screen. We can see 2 planes. We can see your microcatheters well in place.
Would you like me to start or would you like me to wait? You finished with Velo?
The Velo is going on, but we can finish with you first now.
Because this will take, once we start, we don't want to stop in between. So,
okay.
If you think, if you're going to give us some 30 minutes together, we can start.
Do you start, sir? No issues.
Are you sure? You're okay?
Yeah, we are okay, sir. Go ahead.
Okay, so can you see my face? Is it possible? I don't know.
It's covered with mask, but we can see it.
Yeah, I mean, that's good because you won't see my great looking face. I'm assisted by Santosh, my colleague.
Hello, Santosh.
Sahir is, of course, our fellow out here. I mean, the one who's blinking. We got a beautiful little anesthetist who's very shy, doesn't want to come in the front. And that's our lab. So we're just ready to start. Okay. So what we have done is exactly what we told we'll be doing. You can see several markers there. The distalmost marker is the tip of the sonic.
Okay.
The marker just proximal to that is the marker for which you're going to inject glue. And then, of course, you've got a detachment zone. Again, one more time, in the meningeal artery, detachment catheters are not so important. Even if you pull, nothing happens. So what we're going to do now is we're going to actually start injecting Minox. Can I have the saline? Is this saline? We're going to inject Minox. And give me a blank roadmap, please. And when the Minox refluxes, we will inject glue through it. So what we do normally to the second catheter, we already prep it with dextrose. Can I have dextrose here, please? so that it's prepped and ready. This is so that we don't lose time at that point. So, we use this more for AVMs, but we thought we could also show it here because it simplifies the other technique enormously. This is just some contrast that was there already. Can you take up that roadmap, please, for me? Can you give me some more dextrose? Okay, we have prepped it with dextrose, and Minox is exactly the way squid would behave. There's no difference at all. So we are in the onyx mode. That's why every time there is and this is saline, is it? Okay. So I'm just getting ready to inject the Dinoc DMSO. I know they say go slow and measure, really not too bothered. We just sort of inject it. Okay, fine. And give me the Minox, please. Yeah, we can go to the 6 mode.
So there is a poll here if you want to. So we are just running a poll simultaneously of people's preferred liquid embolic agent. As you said, we can use anything, and I don't think it really makes a difference.
So we started injecting. Can I have the lights in the back off, please? What's something feeling on the top or? Can't see the marker really. Yeah, is it? Something feeling, yeah.
Okay, we can see it coming out of the catheter now.
Yeah, it is coming out of the catheter and we are going forward. Can you give me the glue, please?
So there's a question like, why don't we start with pressure cooker? Is there any disadvantage? And
No, nothing. So we're going to do that exactly right.
Yeah.
That is just going to do that. So now we're going to inject glue through the other catheter.
Mark, you want to add anything? Dr. Mark?
Well, the glue is coming.
Yeah.
So we have kind of injected so it's reflux back a bit.
It's covering the detachable tip now.
This is the catheter we pulled, right? I'll just pull it out.
Yeah.
Matthew sir, are we okay with the positioning in the lateral? Can we raise the table so that we can see where the embolic material is?
No, we are going to go to Live A. You'll see much better from now.
Yeah. Okay.
Can you go to a large Live A?
Mark, do you want
So
to?
what is the percentage of glue you have used here?
50%.
50%?
It's always 50%, sir.
But you have covered the detachable tip with glue. Are you not worried?
Yeah, I was not too bothered here. Normally I wouldn't do that. So now you can see the onyx is just going forward.
If you, like as I just said, like if you can raise your table, we can see the occipital area much better.
Oh, you want to see the occipital a little better? Okay. Yeah. Can you just raise the table, the lateral plane a bit? Okay, that'll be enough.
Panelists, and I'm a makeshift moderator.
So Matthew sir, how much you want to come back with the reflux with Minox so that you can inject your plug?
I can't hear what you said. Sorry. I couldn't hear.
I said that you injected Minox fast and you wanted the Minox to reflux a little bit on your
Yeah. We just wanted the Minox to reflux a bit so that we can inject the glue, which gives us a much more stable kind of a cast, and then so we just injected a little fast. You're very right. But having said that, I'm not happy with the way Minox is moving.
So is there a danger of the glue migrating and occluding the catheter tip?
No. That won't happen because we don't allow that, right? We wait for the reflux and only then we do it.
Is the Minox now reflux back?
No, that's not reflux, it's another branch on the other side.
Okay.
It's not the branch through which the thing is going, but it's just a waste, to make stuff go that side. It doesn't serve any purpose.
Dr. Matthew, is that venous sinus functional or dysfunctional? The plan is...
No, it is dysfunctional.
Dysfunctional, okay.
There's very high pressure, so it's actually dysfunctional. So you can see it's all moving forward. So the advantage is you save that big time, which you would normally wait and try to reflux. So we forgot to show you the main angios. I kept it to see. There's a pretty large supply coming from the tentorial branch of the superior cerebellar artery. My fellow told me the name. I forgot the name. And Vishnu, what's that name you said? If I remember, it does sound impressive, but it's a tentorial branch from the superior cerebellar. Well, the key thing we wanted to show you is the advantage is we spend a lot of time normally preventing this reflux, and you realize that one additional microcatheter, and for all of you from India, an Oxford is fine to inject.
Okay, the code word is spoken.
Yes, correct.
So, I'm just having a question here. Any experience using balloons to create a pressure cooker and then injecting? We have been doing this for a few of our cases, and we feel that it also works in a similar fashion, that you create a very quick pressure cooker with a single catheter, inflate a balloon and then inject. Any experience from the panels, Dr. Karapurkar sir?
Yeah, we quite frequently do that.
No, we use just a marathon most of the times, and we just do the marathon.
Mark, Dr. Mark Rebo, any experience with that?
So we actually tried that, and there is a little bit of a problem we found. We inflate the balloon, start injecting, then we sometimes found the balloon is not as tight as we wanted because of reflux. Once we had a vessel rupture. Suddenly we realized that this is much simpler and much easier and also cheaper, because you know that Oxfords are not too expensive, right?
Yes.
It's free.
Yes, you got it right.
Somebody's paid for it.
Can I have one more? No.
Yeah, Dr. Gaurav, we are using many cases of dural fistula or pile fistula using scepter. But what we do, we take it like a smart mask and we take care of the balloon. It should not be overinflated, as sir said. And most of the time, we have never encountered any.
No, sometimes while injecting, I find that it's refluxes around the balloon,
That do happen. That does happen, because.
Yeah.
So.
And then we keep injecting little more. You know that what happens, right?
We use the scepter only in the occipital. If you are going into the middle meningeal, we don't use the scepter.
So, the occipital is the best place for this technique.
Yeah.
If you go distally in the occipital, put this a little proximal, it works out really well.
Yeah. Sometimes it happens that it goes into another branch of the occipital, and then it keeps going into the branch of the occipital. It doesn't go towards the fistula. That also happens sometimes. But by and large, whenever we need to use the occipital, we always use a septum.
I think for occipital it's especially useful for penetration through the transdiploic branches because they don't perforate through. Yeah.
So the transosseous branches get penetrated better.
So here you can see the occipital artery filling up. You can see it well on the lateral. And that is the aim, and we got occipital supply from the opposite side. So we hope that it fills up.
So actually that is the aim. We fill the venous side from the arterial access that we have got. We fill the venous side. From the vein, it refluxes into all the feeders. So when you look at the cast, it will look like a caput medusae.
Can you take an injection?
You will see all the vessels.
We'll just take an injection from the vertebral catheter just to show you the supply from there. That's a large supply.
Oh yeah.
So you can see that.
So it's a big artery.
Of course, it is reduced quite a bit already. But there is a large supply.
So because of this reflux, what one should keep an eye on is there a tentorial artery supplying from the ICA? There are instances of reflux into the tentorial artery and going all the way to the ICA. So when we are doing that, when we know that there is a tentorial artery, we always keep an eye on how it is backtracking into the tentorial artery. And if it is going, and similarly from the occipital sometimes branch and anastomosis with the vertebral. So if it is likely that it is entering the vertebral, we stop at that point. We have to make sure that it doesn't go into the vertebral and into the ICA.
So actually we call this the modified pressure cooker, because the original pressure cooker describes pushing some coils and injecting the glue in the coil before we start the distal catheter or the onyx or minox injection. Here we just allow a reflux and then continue with the minox injection. So small modification that seems to work fine. So we have sort of stopped using balloons completely. This is the only thing we use every time.
Okay, Dr. Matthew, I will.
You can carry on to Vellore now.
So we will come back to you in 10 minutes.
I'll be very careful of what I whisper into the mic from now.
Thank you, sir. So we go to Vellore again.
No, we're
going to Austria.
Monica.
Sorry, we are back to Austria. Dr. Monica Killer is here, and we can see some beautiful pictures of Dyna CTA. Hello.
We can't hear you.
We can't hear you. Yeah, sir.
You can hear me. That's good. We are. The patient is on the way to wake up. She's fine, and that's good news. And it was a very easy, quick procedure, I would say. On the other hand, this is the way how it won't work. I mean, it's always a little bit difficult to position the microcatheter at the neck of the aneurysm, but you need to keep the marker outside of the aneurysm. I think that is the most important part of it. If you do so, you can see in the 3D, I think you have it on the screen, that you really nicely see that the marker is outside of the aneurysm in the parent artery. But as you can see, the marker always is at the outside of the vessel. It always points towards the vessel wall. It never occludes. And I think this is something you need to get familiar with when you work with this device. If it's positioned like that, you have an immediate occlusion. And I think the Dyna CT tomorrow will almost show nothing anymore. If there are any questions, please.
Yes.
Go ahead.
So I think
what's the goal of doing a Dyna CT tomorrow?
Yes, we usually to perform a Dyna CT in the first day, and then the patient goes home.
Any different learning curve deploying this device compared to apps?
Much easier, and the advantage of the contour is that it forms according to the shape of the aneurysm. And also possible if the aneurysm, and you mentioned it in the beginning, it's not quite straight in the axis of the M1, yeah? That can be positioned very nicely if it's a complete straight axis. But if it's outside of that, it's very difficult. And with the contour, it doesn't do anything because it's very easy. The marker will position it wherever you need it. And you can even do a case which is on one side on the branch, but not in the middle of the artery. So this is really, I think, a big advantage, and it's half of the size. You've seen it coming. It never touches the distal dome, which is much more comfortable than with the depth, where you never know where it goes. And it always protrudes also into the parent vessel, but it has not a V shape. The V shape allows the device to be at the wall of the artery and not with the shoulders of the bed, which are usually occlude parent artery. And this is, I think, the major advantage. The V shape at the neck, the marker outside, and not occluding the parent artery when it's outside. And it's much, much easier to push and much easier to deploy. And you have only 5 sizes. I mean, this is the best of it. Here we thought if you should take a 5 or a 7. I think the 5 might have worked, but wouldn't be so stable in the aneurysm. And usually you always tend to use the larger size. If you have a decision between 2, you always tend to use the larger size. And that's all what you need to take into account. So easy.
So here you used a 7 or a 5?
A 7.
7. Okay.
Because probably, could have worked with a 5, but it would have been very small, I would say. It's really on the edge of a 5. So the 7, as you could see, much easier. If it would have been very shallow, did you see that? The 5 is a 3.5 aneurysm width, and we have 3.5 at the neck, and the width is a little larger. So definitely when we have 4.8, which is a little larger, the measurement that it was less than 4 something, then we are exactly at the 7, I think 7 was the perfect size here.
Yeah. Okay. And that was very elegantly done.
Sorry?
I'm saying it was very elegantly done, very fast, very efficient, and we really appreciate the way you did it and described it, and pictures were good. Thank you so much for your help, and we really appreciate your efforts. Thanks a lot. So we are moving out. Thank you. Bye-bye. So we're now going to move back to Vellore. Dr. Sham, can you hear us?
Yeah, you are audible.
Yes. So have you done with the coiling?
Yeah, coiling is done.
Can you show us the picture?
Yeah.
Okay. So these are the runs after we place the coil. We placed 2 coils.
Oh, just 2?
No, two coils. Third coil could not stay inside. There was no place, so we had to pull it out.
What was the second coil?
Second coil was 2.5, 8 centimeters.
So the first was 310.
310.
Yeah.
2.5. And the last coil we took 2 mm, 6 centimeters.
But we still see some filling inside the aneurysm. Do you think stent will take care of that, or there could be a recanalization?
We'll wait and see.
I have a similar case in an ACOM which I'm going to show tomorrow, in which we had a recanalization later on. So that's why I was wondering, it reminds me of that.
Dr. Gaurav, this is a kind of side aneurysm.
I know.
So this might not come again, because significant coils are there, and stent must have created some redirection of the flow.
It's at a difficult angle, so that's why once the catheter comes out, as we said, we cannot go back in again once it kicks out.
Shyam, could you share a bit what was your thought process in selecting this particular stent for stent-assisted coiling, especially when we have so many varieties of them available in the market?
Yeah, one is we wanted to have the option of re-entering to the slot in case if you are not able to get in.
Yeah,
so that we preferred less stent. And secondly, during the discussion time, we were thinking whether to take a flow diverter. Flow diverter we did not want to take the other branches.
We lost you. The audio is not so clear again.
So do you think flow diverter could have been a better choice, being it a side wall and
yeah, flow diverter we did not want to use because
Shyam sir, you're not audible.
Okay, I'll use some other mic. Is this better?
Yeah.
Okay. So flow diverter would have been the other option. But if you are using flow diverter, we have to extend it up to F1. Because too close to the inferior division region. And we do not want to have flow diverter across the other branches in a young patient. So that way we went for plus.
All right.
Okay.
Any other comments or questions?
Yeah, what is your antiplatelet regimen here? Antiplatelet.
And aspirin.
And how long before and after?
We have given about 5 days before the procedure.
And after? For how long will you continue with it?
We'll continue for 6 months and re-enter.
There was a question here.
Is there any way of predicting that the third coil won't go, or is there any way of deciding the coil size, or it's just eyeballing and experience?
Yeah. It was just an eyeballing. Diameter of coil we took 2 mm, but the space is very small. Length of the coil, if you have taken, have stayed inside. We took 2.6. The last couple of centimeters there was prolapse.
So typically we all like to measure, get an insight, but most of the times like it's our gut or instinct or eyeballing which is telling us, okay, this size may fit right. Regarding your third coil question, like when we are putting the second coil, we know how much of resistance is coming in, how much the catheter is being kicked out. That sort of tells you whether this may or may not go in. So it's more of a feel which we usually get. I think that's how I feel it.
Yeah, that's true. And when we saw in the two views here, the frontal view it was showing good density, whereas in the lateral view we could see some spaces.
Okay.
And other thing here is to measure the elucidable density. This is difficult because the peripheral artery is also involved. So somewhat like a fusiform aneurysm is partly.
Thank you.
And we also would like to thank Dr. Rupert Patkar, who gave us suggestions regarding the management of this patient, so taking his input.
Okay. So, Dr. Shyam, we're going to move away. Thank you so much for showing us this case. And we'll see you here tomorrow.
Okay.
All right.
I would like to introduce my colleague, Dr. Vinu is here. He may have some comment.
I think we have lost the video. Is Vinu coming tomorrow here? We will meet him here. Oh, yeah, you're back on camera. We can see Vinu. No, we can see you. Where's Vinu? No. Okay. I think we lost the audio again. Okay, let's go to Coimbatore then. Sir, we are back to you. Dr. Matthew?
Yeah, it is going into a different area now.
Yeah.
Ascending pharyngeal.
Dr. Matthew, can you hear us?
Do
Do we have an audio with?
Matthew, sir? Yeah, hi. Mic on, sir. Yes, so actually we are, is the mic on?
Yes, your mic is on, we can hear you.
So what's interesting is, see, there is a component at the sigmoid which actually is filled by the ascending pharyngeal. And once if we, I don't know, if we can go out of the roadmap, we can show just to go the roadmap. Interestingly, it just come out of the roadmap. So you can see that it is not, it's also started filling that segment, which was rather surprising. That is just a type 1 fistula, it's just antegrade flow, we're not bothered. So we're just doing the job, but for some reason the forward penetration reduced a bit. Okay, let's go back to the roadmap. Flow has considerably reduced, but there is still some left. Just to show you again what was happening is, though our intention was not really too much to inject on the where is it going now? I think it's right within the main cast, and it has to fill the occipital arteries retrogradely, which is, it just started and stopped, you know. I don't see more movement of the cast.
So do you think squid 12 would have a better penetration?
No, it's got nothing to do with that. This is not such a small fistula. We have no difference between squid and Minox, seriously. It is just that for some reason.
This is a Minox 18?
This is Minox 18, yeah. But some of the catheter seems to have got blocked, you know. I don't see any movement, and if that happens, then I have to go through the occipital artery, which is not the best artery to take. You know, we had just stopped for a very, very small moment, but it does look blocked, you know. Yeah. Because I'm getting no movement whatsoever. So if that happens, we will probably, no, I'm not getting any movement, there's nothing moving.
Then it might be safer to stop.
Yeah, it's always safer to stop.
Yeah, because you might.
No, you're not very happy about it, but.
Yeah.
Okay, so anyway, let me stop because nothing is moving. I'm going to show the pull out, which is, of course, pretty straightforward. This is a detachable catheter, but even if it wasn't, we wouldn't have had a problem, you know.
Do you neutralize the heparin?
No, not for the dural AVMs, only for AVMs.
You do.
Yeah, but here it's at the meningeal artery. We'll just take a few injections, just see what we'll do, and then we'll give us a little time and we'll go to the occipital artery and get back to you.
Yeah.
But in the meantime, let's just see the runs.
Yeah, exactly. Let's see.
Okay. We're gonna be here for some. We're gonna be with you for a long time, as I can see.
Pardon?
I'm sure we're gonna be with you for a long time.
No, may not take too long. Just flip, my friend. What are you doing? Go back.
For sake of discussion, would you think Arvind's technique of injecting from the vein, like
injecting from?
Injecting on onyx or whatever liquid embolic directly into the vein would have been, because since it's already deconstructive.
Oh, coming from the venous side and doing
just
that?
Just enter the vein and fill it with onyx?
That's also an option. Like transvenous, you can do onyx glue, combination of coil glue or onyx. I think it's a possibility.
No, but here you see the access is not going to be great.
Yeah.
These are more or less the transverse sinus is all sequestered. So access is going to be very challenging here. It's in the trochlear. The arterial is any day much easier.
Yeah.
So we have a lot of funny vessels in the occipital, not a single vessel that we can really get, but
Do you think occluding the transverse sinus will be an option here?
Actually, transverse sinus is already occluded. No? It is incarcerated.
It's sequestered.
Not totally, but laterally it seems to be occluded.
So do you think completely occluding will help us getting a cure?
Yeah, you're right. I mean, it's a potential option where you just it's a non-functional venous pouch. You just occlude the venous pouch. The velocity is not, it's not a high flow. It's not like a ABM kind of high flow. They may occlude. In fact, like many years back, there was a big series from Hong Kong, a few hundred cases, where he was just occluding the venous pouch and then gel forming the arteries more proximally, and it was working for him.
So what we're
Actually,
going to do, Dr.
that is
Matthew?
what we were doing in the 90s and in the early 2000s. We were going from the venous side. We were only occluding the venous side.
Suddenly we change the way we look at it with onyx. Otherwise, occluding the venous sinus.
Sir, what we're going to do, as you plan your next thing, we're going to move to the next center. We're going to come back to you, and we're going to move to the next session here. So, thank you, everybody, and we're going to move to session 3 now.
Well, I must say that was quite a remarkable live session indeed, and we all learned a lot. I would just say that wherever the heart of medicine is, there is also the love for humanity.
What kind of fistula is it feeding?
Anybody who would like to pitch in any closing remarks for this session is welcome to do so. And I would like to thank our moderator for the session as well as our panelists as well. It has been quite remarkable indeed. Everybody, can we have a round of applause for them? Thank you for coming in here. Yes, sir.
I'll just make a few comments, especially for the young people. The MCA aneurysms that we saw were both incidental, or the three of them. So surgical option we should not forget, it is always possible. And I'm sure we have many surgeons here who would clip these aneurysms. So surgically it is very easy. You just open the sylvian fissure, you get a temporary clip on the M1, and those aneurysms are easy to clip. Many of them. So don't forget a surgical option. That's one thing I would say. Second is, when we are using a contour, the contour we have to position at the neck. That is the important thing. The difference between the web and the contour is, the web has to go into the fundus. The contour does not have to go into the fundus. It has to stick at the neck. So it should be a little bigger than what we have measured. It should be at least 1 millimeter bigger than the neck that we have measured. Somebody asked about the coil, the third coil. The first and the last coil is always important. So you have to plan which last coil you will use. And if you find that there is space, if you can reposition the microcatheter, you may be able to get an extra coil inside. And at least I believe that at such times, start with a small coil. So you have a 1.5 F coils also. 1.54 mm coil is often good when there is a very small residual space left. If a patient has had a convulsion, a 2-year fit-free interval. Cortical vein thrombosis is much more common for patients who have had cortical vein thrombosis and then have dural AV fistula. To have convulsions is more common. So there again we give for 2 years of a fit-free interval. The other question is, if the sinus is occluded, patient has come with sinus thrombosis, and now patient has come with a fistula in the place of the occluded sinus, whether we should give anticoagulation. That is something which we debate with ourselves, but I don't think we have arrived at any definitive conclusion. Patient has come with sinus thrombosis, IVT, intracranial venous thrombosis. 3 months later, 6 months later, 1 year later, patient comes with a dural AV fistula on the same sinus. There should we anticoagulate. I don't know what the answer is. I don't know whether anyone else will have the answer to that.
Suppose a patient, you have done the coiling and all, and the patient is extubated, no deficit, and patient throws the seizure, what will you do? And yeah, suddenly he has arrest and after the seizure.
I think we will do imaging. So here, if you have a dynacity, you do the dynacity to look for any hemorrhage or infarction, or I think some form of imaging would be required. If you don't find anything, anticonvulsant.
Okay. Will you go for the DSA again?
Yes, if suspected, of course. And what you're saying is very relevant. We had one patient, we did a wonderful job of stent-assisted coiling, and the patient came outside, never had fits before. On the trolley outside the cath lab, she had convulsions. So we took her back inside, we did an angiogram, everything's all right. We did a CT, everything was all right. So anticonvulsant. So there we had to give it for 2 years.
Thank you. Thank you.
Thank you all. I would like to inform you all that we are running a bit on time constraints, so we would continue with the questions during the networking break. Moving on to our next session now, I would request the humble presence of our respectable moderators to kindly join us here on stage, starting with Stephen Shaw, Sir, and Vivek Gupta. Ji, ki wo yahan aaye. Let's welcome them with a round of applause, please. Followed by the panelists of this session, Paul Bhogal, Mohammad Shafiqul Islam, Vikas Gupta, Mark Rebo, and Girish Rajpal. Let's welcome our venerated panelists with a round of applause, please. Everybody, hands up in the air. Thank you. We would be commencing the session forward. I would request our moderators to humbly take the lead on.
Thank you. Oh, great. If you, sir, if you can stand here, I can coordinate with you. Acha, ठीक है. So you take that. So we are going live from the Manipal Hospital, Bangalore. So this is the case, what they are going to do. This is a 65-year-old female who presented with compressive symptoms since 1 month. So this is a CT scan coronal section and MRI axial section. You can see that there is a paracellular mass which is partially enhancing, suggestive of partially thrombosed aneurysm. So this is an angiogram. You can see that there's a partially thrombosed aneurysm in the cavernous IC segment. So these are the management option. Let's see what the operator wants to do. Can we go live to Manipal? Yeah, hi. Are we audible? Hello, Dr. Paritosh. This is Dr. Vivek Gupta. How are you? Can we check the audio link? I don't think we are audible there.
Hi, everyone. Can you hear me?
Yeah, we can hear you now. Yeah.
So, right now we are putting a flow diverter across this aneurysm. So we have taken basically the ATES balance system within that CAT5.
Okay.
And then Advait 21 microcatheter, we can see it in the proximal MCA there. So we are at that moment now. We are trying to arrange for the P64 flow diverter.
Okay. So can you start sharing your screens as well? Yeah. So you already have an access across the aneurysm, and you are just going to put the flow diverter or some coils as well?
This is a cavernous segment aneurysm which is presented with ptosis. So we are just putting a flow diverter across it.
Okay, great. So you can proceed.
So my question would be which is the setup for your flow diverter implantation? What are the catheters and which device are you aiming for?
Right now we are putting the P64 this thing. So prior we have put Relive, pipeline flex, the cell. So those are the usual things which we have put. And today we are putting the P64 prototype here.
Okay, thank you.
Can you hear me?
Yeah, we can hear you.
So the problem here is there is a very large mass here. We are able to see the native thrust is very well. The aneurysm is just kind of.
Paritosh, your sound is not very clear. Can you move your mic slightly away from the mask?
Push the one.
Yeah, now it's better.
So the native vessel visualization is a little bit of a guesswork because the aneurysm is completely 360 degrees into it, and we are kind of doing this. This is also from the horizontal segment of the cavernous ICA. So we are planning to put it the start with from the ophthalmic artery, which we have some idea of.
Yeah, go ahead.
The lights on.
Paritosh, we have lost your sound again. Yes.
Sorry, close to close.
Short.
Yeah, okay, go ahead.
I have last with me, who is the main person in this lab. I am just an assistant. Dr. Somini is the one who is the anesthesiologist. What I was saying is that the visualization of the main vessel is a bit of a challenge because whatever we try in this uniplane system, the aneurysm always seems to superimpose on that vessel.
Yeah.
We have some this and the aneurysm next is in the horizontal segment of the cavernous ICA. So yes, the plan is to put across the aneurysm. The size we have selected is 4.5, 4.527. The vessel diameter is somewhere between around 3.75. So 4.5 elongates to around 40. So I don't think we should have length considerations, but we will see.
Okay.
The patient is preloaded, of course, with aspirin and this patient also has a contralateral ICA, but that is not systematic and that is smaller. So we probably just follow it up for now.
Okay. So I think they are ready with the case. Already the patient is loaded with aspirin and Brilinta. And what he was trying to say was that the aneurysm is large and it is in the horizontal segment. So positioning is not so good in the sense in any of the views, they are not able to see the neck clearly. And this, which is true for all the aneurysms which are incorporating the parent vessel. So that is the challenge he was talking about, I think, whatever I could make out. And they are using 4 by 4.5 flow diverter, right? Yes. Okay. So you can begin, Paritosh?
Yeah, we are already on my arms.
Yes. Okay. So anybody from the audience, this question was proposed, will you prefer some coils with FD? So predominantly the answer is yes, 17. But again, the point Paritosh was making is that it is in the cavernous segment, so it is an extradural aneurysm. So whenever it's an extradural aneurysm, putting in coil does not serve any extra purpose. But yes, initial days when the experience with flow diverters was not so good, so people were putting coils in all the extradural as well as intradural aneurysm. But as the things stand now, for extradural, they are not required. So probably I differ with the majority of the audience, and that's the norm presently. So what do our panelists feel? He's deploying from almost from the ophthalmic segment till the ascending portion of the cavernous ICA. So is this positioning optimal, or anything else can be done? Your views?
I think there is another reason not to place additional coils in the aneurysm site, which is the fact that it's partially thrombosed. So you know the reason to place coils is to prevent delayed rupture.
Yes.
But what is the risk of having a delayed rupture, singularly in an extradural aneurysm, when you have a partially thrombosed aneurysm? So probably it's not completely necessary in that case to place additional coils. I mean,
true.
But okay, you can do it. It's not, I am not saying that it's a problem to do it, but let's say that I am not sure that it's mandatory in this situation.
We agree, sir. We agree. Yeah.
I have one question for Paritosh. Was he able to cross the aneurysm straight, or did he have to make a loop in the aneurysm?
I was hoping we could see how he crossed, because it looked like a tough crossing. So Paritosh, the question to you by Dr. Karapurkar is, how easy or difficult was the distal access?
So Ullas crossed it very, very well. There is a loop. I will show it to you. Okay? It's recorded.
Okay.
I will show the way he crossed, and then we will try the answer. Yeah, this should be. Now, previous started from before. Okay.
Before this, it was coiling in the aneurysm for 2 or 3 attempts, and then we were probably lucky to get into the
So this is where we got into this neck of the aneurysm. Go ahead.
Which wire was this?
So this is synchro select
standard song.
Yeah. So this is. Yes.
Yeah. Okay. Okay. Not that bad. You didn't have to take the entire loop, but still, it was a difficult crossing. Yeah. So do you have the fluorostore where you straightened the catheter?
Yeah, so I think we'll deploy from here.
Sure, sure. Please go ahead.
Do you deploy distally the AP plane or lateral plane, or you have biplane?
We have single plane.
So we have single plane only, sir. I think both planes, the distal and proximal, are well seen on the lateral, and we are not able to see in any plane the artery which is within the aneurysm. So I think we will start in the lateral and end in the lateral also again.
So this is our main view, sir. Whatever view we are having now, we are deploying in the same view.
What we typically do is to start deploying in the AP plane, because you see the supraclinoid ICA better in the AP plane, beyond the aneurysm. And you won't have to stay below the bifurcation, if possible below the PCOM. So here I think you are at the level of the PCOM, the distal end. I think we won't disturb them, let them finish.
We've got the distal anchor, so now we are just deploying this aneurysm, FD. It seems to be opening up as of now.
Stephen, how do you feel about this particular bend which the FD just took?
I have one question before I answer that. So I understood that would be a pipeline case, but I think that's a P64. Huh? Did I misunderstand it?
The device? Mm-hmm. P64, yeah.
It's a P64.
Yeah.
And my question would be, you could use the distal wire to stabilize the setup. I think you can put it like 6 centimeters distal to the end of the flow diverter, and in such situations, I think this is a very helpful feature.
Paritosh, could you make out?
Let him finish deploying, then we ask him the question.
Is he able to hear both our voices, Paritosh? I think right now he's concentrating on this, then we'll come back with the same question again.
Okay. The thing is, I had a comparable case, and in that case, it helped me to gain distal access again. So have the wire in a very distal location can help you to get like through the flow diverter if there's any problem without losing access. And I think especially in those large cavernous aneurysms, this is very helpful.
Okay. Any comments from the panelists about the longer device, the difficulty in deploying the longer devices? Like this is 45, fairly long device.
So I would have a question to you, Vivek. What do you think about the proximal landing zone? Where would you try to end the flow diverter proximally?
The question is, where will you like the device to end proximally?
Correct. From where to start, right?
Proximally.
Proximally, okay.
Where will you end? Where would you like it to end?
You feel it's too distal, too proximal?
So I personally would think close to the petrous segment. I mean, we have I don't see the relationship between the aneurysm neck and the parent vessel in this projection very well, but I think it should be a very safe approach in those kind of procedures. So I would aim for a rather proximal landing zone.
And other occupants. Sure.
So typically, what should we do if the device is not opening like this? What's our bailout?
So, you want to address that, Stephen?
Well, I actually think it will open just nicely. But if you have problems with opening the P64 proximally, in my experience, just manipulating with the microcatheter and the wire a little bit will do the trick in most of the cases. Like reprobation with a microcatheter and using a stent retriever or a balloon is rarely necessary.
Correct. So there are two stages to what Gaurav is asking. If the device is not opening, if you are at this stage when it's a longish device and around the curve it is not opening, so one needs to resheath it and deploy, center the catheter and then redeploy it. You may have to do it twice or thrice. So generally it works. And the other scenario is when you have deployed the device and it is not open fully and you are stuck with that. That is where what Stephen is saying, that you probably will need to recross the device, bump it little with a guiding catheter or a distal access catheter, or in worst case scenarios, you put a balloon and do angioplasty. And there are many operators who do angioplasty in FDs routinely. Like the UK group, they do it routinely so that the wall apposition is very good. So both the strategies work.
And you can help yourself with the intermediate also. Bring it up and.
Sorry.
When you deploy, if you bring the intermediate catheter higher, you can always.
Correct.
Correct.
So, yeah, you have what you are saying essentially is that to have a more distal control, so that you can manipulate the device in a much safer way. True.
Do you think we need to push the intermediate catheter up? Vivek here. First line. Do you think just pushing the intermediate catheter a little bit will give us more stability and predictability?
Yeah, I think so. That's what
Mark
was. Yeah, that's what he was suggesting. That the intermediate.
What was I saying?
Correct.
I would agree.
But device has opened up reasonably. Just a small segment is left. The horizontal portion, I'm not very sure whether it is just not open or there is
Dr.
some.
Paritosh, can we have the intermediate catheter going up slightly?
Paritosh?
I would agree with what you just said. I think having the intermediate, can't really see it. I think that's causing additional problems.
Paritosh, can you hear us?
Yeah, I can hear you.
Okay. So one of the suggestions is that your DAC is low. So if it is feasible for you to take it higher up so that you have a better control.
Come up.
It's just going up. It's going there.
So I'm not really sure, but I have the feeling that the distal landing zone has come more proximally. So I think there's a slight proximal dislocation, and maybe at the point, at the exit zone, there's a slight twist in the flow diverter, which is why it's not opening completely at that point.
Okay. So Gaurav, question to you. Would you go more distally with the DAC?
Do you think there is this kind of twisted a little bit?
I will do an intra-cat deployment here. So I will take the cat till the point where it is not opened up, deploy it within the cat 5, and then push it out with the microcatheter. And then if that's what he's doing now.
Correct.
That's what he's doing.
That's what he's doing.
Exactly, and you push it with the DAC.
So that's the last resort, or for some people, it's the first thing they do whenever device is not opening. It's the longest device. You do an intra-catheter deployment. So that's what he started to doing. But is there a twist at this point? What Stephen was asking.
I don't think there's a twist. I think it just. See, my assumption is that the device is pulled proximally, like there's too many turns. So the intra-cat deployment, once you do it, it will get free from its proximal end, like what he's doing now. Now the device is free, it's going to bulge a little bit, it's too much of a push. And then it should open up, and then you just cross and then do a plastic. Yes. In a dysplastic giant, sort of like large aneurysm, not giant. More often than not, you end up doing this.
Correct. At this particular point where his DAC is at this point, this is the point where it's not opening. So
he just needs to push it out. He has already deployed, I think, within the Cat 5, if I'm not wrong. Whatever it is.
Is it a Cat 5 or a DAC?
It's a Cat 5. It's a Cat 5.
Cat 5, yeah.
This point is not very sure at this point. So Paritosh, what do you feel is happening at this horizontal segment? What are your thoughts?
ऊपर ले जा सकते हैं और ऊपर ले जा सकते हैं एकदम से डायरेक्ट को जितना ऊपर ले जाओ अब लाइन ले लो
Do we switch?
How many miles over?
So the one of the active poll question is what should be done? What should be the best rescue plan now? It looks that the device is giving some problem in the horizontal segment. So Stephen, what would you do out of these four things?
So I would be a little afraid that there might be thrombus around the portion of the flow diverter which is twisted, so that it might not open eventually. So I personally would be too afraid to redeploy it and would change the device, especially as we have access to the distal vessels. So there's no problem. We don't have to reprobate the vessel. So I would just exchange the flow diverter.
Okay, so you change the device, right? You feel there is a thrombus around that. You would like to change the device, right?
Yeah, I would like to change the device. I would aim for a more proximal landing zone so that we can enter it in case there's any problem. And maybe just manipulating a little bit would then open the device.
Okay.
I think it looks all right.
Okay. Go ahead, Paritosh. You are taking a run now. Paritosh, can you show us the unsubtracted images?
Just unsubtract.
There,
Minus 1.
you can do it there.
Just to see the device. Yeah.
The remote, last button.
Okay.
That artery itself is quite narrow. In portion where the thing is.
Yeah, so it's not twisted or anything, it's just open, but the size of the artery, we don't have any way to confirm how big or small is the artery at that point.
Try.
If you have 3D images, so yeah.
Now, do we have the camera there outside?
What I would find very interesting is to know the distance between the aneurysm neck and the distal landing zone. So how much place do we actually have in the safe vessel, in the healthy vessel? I cannot really see it.
Yeah, same here, I can't make us.
Do you have any camera to shoot that side? Shoot at that side?
So even with the dark just wedging against the unopened segment or partially open segment, it's not open. So there is an issue. So the question is that is it better to do deploy the whole device and do angioplasty after that, or do something else, resheath or change the device?
Device is already deployed now. You can't. Device is completely deployed.
Oh, it's deployed. Okay, right.
Show them.
I think the only thing they can do now is to put a wire and put a balloon and do the plastic.
We're just trying to show it on the.
Okay.
That is being zoomed there. I'm not sure whether you'll see that. This is the. You're able to focus?
Yeah, now we can see that. So it's actually a very bad looking neck. There is hardly any neck. It's just complete incorporation of the vessel. That is the reason.
And there is also that stenosis appearance which we are having.
Okay.
That appearance is there in the prior 3D itself.
Okay, what Paritosh is saying is that probably there is a stenosis here, and this is the exact segment where the device was not opening fully. So that's where they are facing challenge. And what do you feel, Stephen? Angioplasty should be ideal in this, because there appears to be some stenosis on these images, at least at this point. What?
Actually, the stenosis was there from before. So.
So, Paritosh?
Vivek, I think it is
Sorry? Paritosh, what we are going to do now is, can you hear me? Yeah. So what we are going to do is that we are going to switch to Coimbatore for 5 minutes, and then we'll come back to you, and then we'll continue with your strategy, how you are managing this. Is that okay?
Sure.
Okay, great. So we'll switch to Coimbatore, where Dr. Cherian is finishing his case. I think he's finished. Can we switch? Dr. Cherian, this is Vivek.
Yeah, hi.
Hi.
So, Vivek, so what we have done, we did the exactly same thing on occipital artery, put 2 catheters,
okay,
and glued the proximal part, and distally we got another micro. So we have most of the transverse sinus with the fistula is gone, but there's still some filling coming from the vertebral side,
Okay. Can you show us the last run you have taken? Just
Yeah, we just show it to you. So you can see that mostly gone from the occipital and the carotid segment, but what we have is the vertebral artery has got a direct kind of fistula which is leading to it. Yeah, you can see that fistula like this, coming from the meningeal branch of the pica.
Yeah, pica
So we hope it will retrogradely fill it, so that's the aim.
Okay.
But it's 90% gone, just a little bit left. So, one of the things is, by gluing or doing some form of way to prevent reflux, we can save time. We can directly inject, So here the thing, I'm just waiting because it's going more into the superior sagittal sinus rather than coming inferiorly to take that branches off.
Correct. We don't want to put more in the sagittal sinus.
The branches are more from the inferior side, but this is a problem with all these liquid embolic. It's got a mind of its own. We just have to wait and hopefully it just does the job, and suddenly it sort of flows where you want. So right now, again, going into the wall of the superior sagittal sinus. It has been there for quite some time. This patient actually had cerebral venous thrombosis, and then was an anticoagulant. He stopped anticoagulants, then became symptomatic. He has been symptomatic for more than a year. So had some financial problems. So that's how he came for the workshop.
Okay.
So
how long you're going to wait for start injecting again?
Yeah, just stop and inject it. Finally, I don't know if it, by some chance it doesn't go into that meningeal supply of the pica, then maybe we may have to enter that on its own. But most of the time that doesn't happen. It does finally go there,
Okay.
So mostly we got most of the right side of the trochlear. Somehow it's not going to the left. So we can just show it without a roadmap, the spread of gluing. Yeah, you can see it actually, the whole lot of it, it's done a good job, except that we wish it goes a little more inferiorly, that's all.
Yes.
So I think it's after some time boring for the audience because it is slow injection that goes on.
I know, it's a tedious job.
Yeah. You can't push it faster than this. And you just got to wait and hope it. Invariably, most of the times it will do its job.
Okay.
But from our experience, seriously, I've not found Minox anyway inferior. I think it's a good product made in India, and I just keep telling them if they can keep it cheaper to 50% of the other things, it would make a big difference. But can't. Yeah, so we find it good. The radioplasty is good. The viscosity is good. So that's pretty all right, actually. So we do this all the time, 2 catheters and a glue. Otherwise, in occipital artery, we end up wasting a lot of liquid embolic. Here you see there's not much really on the ECM. It could rapidly pass through the bone, transosseous into the sinus per se.
So Stephen, any thoughts on this? Now they have one feeder left, which is from the intracranial circulation.
Yeah, actually, I have a rather non-technical question. So everybody knows it. You are standing there for hours and hours. You do your embolization, your feet hurt, and your stamina goes out. Radiation increases insanely. When is the point to stop? It's a true question, an honest question. I don't know, because you're standing there and you think it's just one feeder, and then there's another feeder, and then there's another feeder that you have to occlude, which has not been visible before. When do you stop? Do you use time, or do you use radiation? Do you use contrast? What is your threshold?
I think most of the time we are able to stop before the 10 gray. But I think if it crosses 10 gray, we should stop and just maybe wait for some time,
Okay.
So we have just crossed the 5 gray mark. And we were hoping that, most of it is gone. There's just little components coming from the meningeal branches of the posterior circulation of the pica. If it just moves down, it will be done, But I agree totally with you. We have to learn to stop at some point and not just keep on going. But most of the time, and we know that it's not like an ABM, you can stop at any time. It's not going to bleed or something. And so that way, I think totally agree with you that. So do you have a cutoff point?
So honestly, I don't have the numbers, but if I'm too tired and I think now is the time that mistakes could happen, then I step out. Or I ask my colleagues to step in. Because I think the patient does not benefit from very long embolizations in such cases. It's just my opinion, because then after hours, my concentration is really dropping, and maybe I would do mistakes that could be avoided in a better situation.
So one of the things, we are very comfortable having another colleague by the side, because one thing I agree that this, somewhere down the line you start concentrating and suddenly you find the embolic going somewhere which you didn't want it to go. So it's a lot more comfortable to have at least another person with you.
So
especially after some, I think it's a luxury to have another person.
Oh, definitely. So
Dr.
what we
Cherian,
do...
So what we are going to do for some time is that you please continue doing this. We'll come back to you. In the meanwhile, Stephen has a talk. So can you do the talk now?
I can do the talk, but I think Laurent would be on the line first. I don't know. On the coating, I'm not sure. So I can do the talk, but okay.
So we'll proceed with this talk, and then we'll go back to Paritosh and Matthew after that.
Okay. So
by the way, I just want to see the microcatheter duos also. I mean the single tip where
Okay, please go ahead. There was some problem here.
Okay, so my topic for today is indirect flow diversion, and we have started indirect flow diversion a couple of years ago, and we asked many centers to send us their experience. And I'd like to introduce what we found. So we published it last year, and I'm going to start with the concept of conventional flow diversion, which everybody knows, but it's important to reconsider what actually happens if you think about indirect flow diversion. So flow diverters don't treat the aneurysm itself, they treat the diseased vessel wall. And implantation of a flow diverter over the neck of an aneurysm has kind of three different steps. So first of all, there's a hemodynamic downgrading, then there's thrombosis, and then there's re-endothelialization. And the endothelialization is required for healing, and it happens from the proximal and distal landing zone towards the center of the device. So this is the established way of flow diversion. We have an aneurysm, we catheterize the parent vessel, we implant the flow diverter, and then the aneurysm is occluded after some time. So in principle, the mesh targets the interface between the parent artery and the aneurysm. There's a very nice study, 2020, from a Korean group. They have investigated histological sections after flow diversion, and they only did H&E stainings, which I find very impressive in nowadays. So what they did is they did carotid sidewall aneurysms in rabbits, and they did angiographies 4 weeks later, and they found the most preferable pattern, of course, is complete thrombosis of the aneurysm sac, shrinkage of the aneurysm, and a thick line of endothelium around the struts of the device. The problem is that not all aneurysms are amenable to flow diversion. So we all know these aneurysms which are kind of close to the main artery, but not directly. They arise from a side branch, and they are also not a good target for like coiling or stent-assisted coiling. So what could be an option? And I think many centers are actually doing it. They place the flow diverter proximal in the main vessel which is feeding the parent artery that carries the aneurysm. Here are a couple of cases which we included in the paper. So we have a 40-year-old female patient with an incidental ACOM-A aneurysm. It's 8 millimeters, did not rupture. And if you look closely, we have a closed ACOM-A complex. So we have a small but perfused A1 segment on the contralateral side. So the idea in this case was to place a flow diverter from the A1 to the A2 segment of the dominant anterior cerebral artery. And 10 minutes after implantation, on the right-hand side, you see that the ACOM-A and the aneurysm are no longer opacified. 24 hours later, the control injection shows that the A1, A2 are patent, and the aneurysm along the ACOM-A is again perfused, but there's a stronger influx from the contralateral small A1. And if you look 3 months later, the aneurysm is completely occluded. And the very interesting portion of this figure is F and E. So immediately or shortly after intervention, you see that the contralateral small A1 is still filling the ACOM-A aneurysm, and 3 months later, it does not anymore, although the aneurysm is not covered by the flow diverter, and there is no flow diverter or stent in the contralateral A1, A2 segment. Second case, we have a partially thrombosed ophthalmoplegic ICA aneurysm, which is compressing the brainstem, and there's not really a good option for treatment for that aneurysm. So here there was a pipeline deployed above the orifice of the ICA, and it didn't really work well after the first control injection. So there was a second pipeline deployed, and then it shrunk. So overall, 17 patients from 5 centers were included in our analysis, and the distance between the aneurysms was 0.5 millimeters to 2.4 millimeters, on average 1.65. Location-wise, we had a couple of locations, the M1, M2 segments. We had the anterior cerebral artery, and we also had different locations in the posterior circulation. If you look to the outcome, then it's impressive to see that 88% showed an immediate hemodynamic downgrading. After almost half a year, half of the aneurysms were occluded, but almost 25 aneurysms did not show any change or any relevant therapeutic result. So what did we see further? There were no clinical complications in the observation period. There were 2 occlusions of covered branches, kind of intended. And if we reconsider what we found, then we could say it's a safe, a feasible approach to treat aneurysms, but occlusion may take longer in a number of cases when we compare it to conventional sidewall aneurysms. So the consideration is, what can we do to improve indirect flow diversion? And that's what I wanted to update today. So if you use coated flow diverters and MONI anti-aggregation, you can actually improve the occlusion times. So we did a couple of cases already and have the follow-ups. And this is one of the cases I want to show you. So here we have a 56-year-old female patient with an incidental aneurysm, but a family history of SAH. These are the conventional projections. And this is the 3D angiogram showing the aneurysm arising from the frontal branch of the MCA. And if we consider the case, so we have a patient who wishes treatment, but she rejected craniotomy. I mean, it would be a fair case for clipping as well. Stent-assisted coiling is possible, but technically definitely more challenging, and recurrence should be added to the equation as well. The aneurysm arises from the superior trunk, and there's potentially an eloquent branch covered, and it's not a sidewall aneurysm situation. So there's a lot of flow in the aneurysm dome. It will take time. That's why we decided to use a low-profile flow diverter with antithrombogenic and pro-endothelial surface modification at the ribo to heal with prasugrel monotherapy. This was inspired by a kind of recent paper which used prasugrel monotherapy with the P64 HPC, and they had very good results as well. So here we have the angiogram after implantation of the flow diverter. There's a subtle hemodynamic effect visible. This is the lateral view of the projection. And this is the control run 15 minutes after implantation. We always do flat panel CTs with intra-arterial contrast to see the device and the vessel in all directions. And this is the early 24 hours post-procedure control. So there is no further hemodynamic effect. We see a very little delayed perfusion of the aneurysm or contrast stasis. And this is the DWI imaging 24 hours after implantation. So here we have the B0 image, and now is the B1000 image. And what we find is in some 3 DWI spots, which are not related to the area of the covered branch. They are probably just small emboli from the intervention themselves. So if you look to the FLAIR image, we can see the hemodynamic effect. There is also slow flow in the aneurysm, and we don't have relevant infarction. So the patient came back 6 months. We usually do a 3 months follow-up. She skipped the 3 months and came back at the 6 months follow-up. And we see that the aneurysm is occluded. So here's the 3D. There is a slight irregularity where the aneurysm was, but the effect 6 months after implantation, I think, is remarkable. So these are the relevant projections. And this is the standard projection for comparison. So there's no side branch occlusion, complete filling of the territory. These are the CTA reformatted images, where you can see that there's a slight caliber change or like an irregularity at the origin of the branch, but there is no significant aneurysm visible. So far, we have 3 occluded MCA indirect flow diversion aneurysms. between 3 and 6 months after indirect flow diversion with prasugrel only. There were no parent artery occlusions, no hemorrhagic or embolic complications, and we didn't see any relevant intimal hyperplasia within the coated flow diverter. That's what I wanted to show you, and I'm open for questions.
Stefan, hi. Rajiv, yeah, this side. Hi. Okay, there's one there. Take it from there. Can I ask my question first? Yeah, thank you.
I'm so sorry to interrupt, but I would like to inform you all that it's 5 p.m. right now, so we have 2 flash workshops happening simultaneously. One is happening at Microvention booth, the other one is happening at Metrotronics Tech Suite. So if you would like to participate or view, you're most welcome to do that. Sorry for the interruption. You may continue.
Thank you.
Stefan, congratulations, nice talk.
Thank you.
And of course, I've heard this before. But, and you've added the new HPCs or the modified flow diverters to this. My question is, do you have any patients in your series who have not responded to indirect flow diversion?
So you mean that if there was any aneurysm that maintained its shape? So the ICA aneurysm I've shown you, that was the most troubling case. It's not yet occluded. It has decreased in size, but it's still, it's still residually perfused. Otherwise, I don't remember any significant reperfusion or remnant.
Thank you.
We'll take one question, please. Then Manipal is ready. Then we'll just go to, first we'll go to Coimbatore and then Manipal. So,
no, just congratulations, it's a very interesting presentation. I had one case of a giant MC aneurysm on one branch of the bifurcation. I treated the aneurysm at the beginning with coils, but it was recurring indeed. And I was treating with indirect flow diversion because it was not easy it was not possible to catheterize a branch where the aneurysm was located. But it was a really giant aneurysm, 25 millimeter. I don't remember the size exactly, but roughly 25. I placed the flow diverter. I do a control angiogram at 6 months, 1 year. There was a very strong decrease in size of the aneurysm, but after 2 years, I still have the remnant of the aneurysm. So maybe for giant aneurysm, we will have very late full aneurysm occlusion, or maybe it will be a limitation of this technique, which will be that we will still have remnant after several months or years. I don't know if you have some experience with larger and giant aneurysm and with this technique.
Not really in this location, but do you think placing a second flow diverter to increase the density would be an option in your case?
Maybe it's an option, I agree with that. I don't know. By the way, I have to mention that the treatment was not done under single antiplatelet treatment, but because it was done 3 or 4 years ago. So it was done under single dual antiplatelet treatment. But indeed, the treatment was stopped after 3 months or 6 months, I don't remember exactly. But maybe you're right. Maybe placing a second flow diverter as the first one is maybe an option. But we don't know, by the way.
Okay, thank you.
Thank you. Thank you, Professor Stephen. Here, Stephen.
One last question, Stephen.
Yeah, thank you. Were they ruptured aneurysms, all of them, what you showed?
No, none of them was a ruptured aneurysm. In ruptured
incidental aneurysms.
Yeah, they were all incidental aneurysms.
You said, I'm surgeon, I'm neurosurgeon. Just wanted to ask. See, 25% of them, you said they were unchanged after the procedure.
25 remained the same.
Unchanged. What did you do for them?
So, yeah, that's what I said. So we have 12% which didn't change at all, and we have 12% with a very subtle change. So I think that's a serious limitation, because the only option that we have is to put another flow diverter or to do very risky things to try to, catheterize.
I'm very sorry to interrupt. We'll have to cut down because our live transmission has begun. So probably, Stephen, you can take this question after this. Thank you so much. Thank you. So can we have audio from the Coimbatore? Is Dr. Matthew online?
Yeah, can you hear me?
Yes, Dr. Matthew, we know that you have done it. So
we just quickly run you through. We got a fantastic result. So this was the beginning, as we told, feeders coming into the trochlear from the meningeal supply of vessels from the pica. Also, tentorial branches coming from the superior cerebellar PC over there. And then we'll show you an ECA supply one more time. Can you just show me an ECS? Yeah. So this is but this is not a good shot. So you can see the middle meningeal was giving a supply straight direct to the fistula. So we access that first. Go on next. Do you have a shot showing the, okay. So that's it. So plenty of branches coming from the occipital artery on both sides. Go to that. Let's go to the treatment proper now. So we showed you that technique we use. We use it all the time today. We use two catheters, like we said, one distal, one proximal. And I'll show you the occipital injection now where we left you. So this is the glue cast that is created after we injected some amount of Minox distally. And if the occipital, it really does a great job. You can see what happens here. We have injecting this. And we get a nice thick chunk of glue proximal to the catheter. And once that is there, you will just not waste squid onyx or Minox. And so you see, once we got this very good position, go to the next one. We could rapidly just go on. Yeah, we'll just show you some shots. In the end, we just come towards the last shot. I think that's enough to show now.
So can you show us the final run, Dr. Matthew?
Yeah, I'm going to show you the final one. But the most interesting thing, it did not take more than half an hour from the time we went into the occipital. I mean, that's why it's good. It saves radiation, it saves time, it saves fatigue. So next one. Show the last one. So you still feeling. Go to the next one. So you can see it's done. There's nothing filling at all. It's a perfect treated fistula. Next one. So that's the branches from the posterior circulation. This is the branches from the occipital, which is gone. Next one. This is from the opposite occipital treated. Next one. And this is the proximal injection from the CCA. As you can see that it's completely cured. But the great thing is, like we started around injecting around 3:30. We've accessed 2 vessels in 1.5 hours. We could complete the whole thing, used about 8 vials of Minox. So just to demonstrate this fact that it's a very simple technique to use 2 catheters and keeping a bit of glue can really save a lot of time and radiation. Thanks so much.
So let's give a big hand of applause to Dr. Matthew. So wonderful case, and congratulations to the entire team. And we'll sign off from Coimbatore now.
You can see all of us, that's a face of Santosh.
Now we can see, yes. Okay.
Yeah.
So
and, I can't see Sahir is here behind. Yeah.
Thank you so much, Team Coimbatore, and we'll sign off from our side and move to our next case in Manipal. So good evening. Bye.
Yeah, bye-bye. Thanks so much. Bye.
Bye. Can we switch to Manipal?
Can you hear me?
Yeah, hi Paritosh, we are back, yeah.
Vivek?
Yes, this is Vivek.
So we did a balloon angioplasty. Show that run. So we took a balloon which is 3.510.
Which balloon?
We did not exchange because the cat was already there inside the FD.
Okay.
So we put a wire and then took this balloon.
Which balloon you have used, Paritosh?
This is inflating. The balloon is inflating.
Mm-hmm.
And that's opened up. So we are also done. Just show the next one. Yeah. So this is where the final result is. And It's opened up fine. We'll take some more runs and then probably we'll let it go.
Okay. So, yeah, thanks Paritosh. So, an excellent outcome after a bit of difficulty. So, congratulations to your entire team, and thank you for sharing this with Nice here.
Yeah, this is Ullas. Most of you know Ullas.
Yes, we know Ullas.
Ask some questions. And my residents, Dr. Somini is there, anesthesia, she's there.
So,
and thanks to Enox who gave us this nice flow
No,
diagram.
Paritosh, it was great to have a case from your center, and it was an excellent case. It was a difficult aneurysm, no doubts about that. And you managed it pretty well, and outcome is very satisfactory. So congratulations to your team, and please accept the applause from our side from here.
Thanks.
So we'll sign off from here and move on to our next case. Thank you so much.
All right, thank you.
So I think we are done with this session, and the next team will take over. Thank you, everyone.
Thank you.
That was quite a remarkable session indeed. Can we have a huge round of applause for our moderator and panelists for giving us their precious time here today? I would like to say something before we proceed forward. Doctors have the opportunity to do more good in one day compared to most people in a month. So keep doing the good work, the hard work. It is all very much appreciated. Our next session is about to commence, and to do the honors, I would request the humble presence of our moderators. Let's welcome them with a round of applause. Vipul Gupta, Srinivasam, Paramisam here on dais with a round of applause. Let's welcome our moderators, followed by our panelists now, VK Dikshit, Trilochan Srivastav, Ajay Kumar, Tariq Martin, Rahul Kumar. I would be requesting the humble presence once again of our venerated guest. And so we have with us Vipul Gupta and Srinivasan, sir, in a few more couple of minutes, sir.
Moderator, Srinivasan Paramasavan. Okay. The next case, do you have the case details?
It's right there. I will ask them to start it.
I would be requesting humbly our panelists to come forward as well. I would once again call upon our panelists, Trilochan Srivastav, Ajay Kumar, Tariq Martin, Rahul Kumar. Thank you so much for your humble presence here today. It is a delight to welcome you here on stage. I would request our kind moderator to kindly take the lead and start the session now. Thank you so much.
Hello, everyone. It's a wonderful evening, and I thank Gaurav for organizing this live cases. It's been quite exhilarating to see the cases from various centers, and we will move on with the next session. I think we've got 3 more live cases to go today. The first case in this session will be from Calcutta by Dr. Sukalyan. That's the live case 9 from Dr. Sukalyan. So the clinical history goes like this: a 45-year-old hypertensive female, non-diabetic, presented with sudden onset headache, moderate intensity holocranial and drooping of eyelids, right-sided ptosis, right third no paresis, extraocular movements restricted on the right side. Next slide. Yeah. So there is an aneurysm in the posterior circulation. Do you have it? Go on to the next picture. Next slide, please. Yeah, you can present this.
So I'm just going to present on behalf of Dr. Sukalyan. And this was the first phase of this patient which was treated, and that's the first picture phase. So we can see the SCA aneurysm. And where's the next? Sorry. Next slide. Okay, yeah. So these were the images. And the patient also had another MCA aneurysm, right MCA bifurcation aneurysm. So they planned initially for the SCA, stent assisted coiling. So they had the option of coming either from the PCOM and going into the SCA, but there was no PCOM. So the second plan was putting a braided stent and putting coils. And that's what they did. They did the coiling first and packed it, and then placed a stent, and it's a Leo which is across from right PCA to the basilar artery. And I think it was a good picture, and they also did the coiling of the MCA aneurysm. So in 4 months follow-up, the patient improved clinically, and the follow-up DSA MCA aneurysm looks fine, but there is recanalization of the previously treated right SCA aneurysm, and that's the picture now. So the SCA is arising at a very sharp angulation, and there is quite a bit of recanalization at the base. So we are here to discuss what to do next for the further plan. You can take over, Sri.
Yep. So, are we going for the polling? Do we have the poll questions, Gaurav? Okay, I think. Oops. Hello, hi Sukalyan.
Yeah, hi everyone. Good evening.
Good evening. Good evening. So we went through the case history, and we know that it's a recanalized superior cerebellar aneurysm. So what's your plan?
Yeah, before discussing my plan, I just wanted to take like what you guys think of, like what you would have done differently in the first place. This aneurysm, whether like it could have been done in a different way to prevent recanalization. This is one. And as Gaurav has already discussed, that there was some plan that probably we could have gone through PCOM, but the PCOM was at that point of time was very hypoplastic. And but surprisingly, the PCOM has opened up now a bit more. And and there was also, we tried to go from the basilar to the SCA, not much, but we tried a little bit, but we failed because it was quite a sharp angulation and it was not entering there quite easily. So otherwise also, like, it was a bit difficult to place stent on that part, which probably will not take that sharp band and come into the PCA. And so that was difficult. So with that part, we thought we will coil the aneurysm and then put sort of an indirect flow diversion. So I didn't want to put a flow diverter, but a semi-flow diverter like Leo, and just wanted to see whether it heals the neck. But surprisingly, at 3 months, there's a lot of coil compaction here. What we can see towards the dome of the aneurysm, and there is recanalization in the neck part. And the SCA is patent, and it didn't change its course at all. So now my plan, what I think at this point of time, I'll again re-enter, which I have already done. I've re-entered the aneurysm through the struts of Leo, and then maybe recoil it, leaving that part of the origin of scar on the right side, and then I want to ask your expert opinion, or whosoever is there, your expert opinion, that should we put another Leo, another short Leo, just to cover the neck part, or should we put a flow diverter, which I don't like to put, at this point of time because there will be a lot of metal and there are quite prominent perforators are there from that area. So what do you think?
Yeah, we had the polling question up there, and we have quite a bit of response towards indirect flow diversion and about very few voted towards coiling. So maybe a coiling combination with the flow diversion might work here.
Yeah. So I will just put few coils just to give some added, and then probably a short Leo that area. Just to cover that.
Before you start, I want to ask you one thing. Do you think this is a coil compaction or do you think it's an aneurysmal growth?
I think maybe it's the combination of both because the overall size of the aneurysm did not change much. It's more or less remained the same, but the coil got compacted because we can see the jet. I'll just show you the angiogram. We can see the jet of the blood which enters there, which tend to push the coil towards the dome.
Are you surprised by it? Because the neck initially was quite small and you had a quite tight packing. Is that correct?
Yes. The neck was around 2 to 2.5 millimeter. Now what I can see is around 2 millimeters, so there is no substantial change in the neck size.
Okay, please go ahead. We are looking forward to your
Dr. Sukalyan.
work.
Yeah, hi.
Ajay here. Good evening. Similar case we did 7 to 8 years before, and the problem was same. There was SCPC aneurysm, and the SCA was coming like 1/3, 2/3 of the aneurysm. So after putting stent and the coiling was done, and on table the aneurysm was doing fine, but on first follow-up what we see, there was recanalization near the neck which was not significant, and at 6 months there was significant recanalization of the aneurysm like yours is having. So the patient, the reason was that the SCA is having some effect and it is asking for blood, and this is why the coil is compacting there and aneurysm is growing from there. So what I did in that particular case, we entered again and sacrificed the SCA.
Right.
And then coiled the proximal, and then patient did well in follow-up. But these aneurysms do come again when there is some patent artery taking origin from any part of aneurysm.
Absolutely.
Yeah.
This side actually there is no good ICA, so the ICA is not there. So that's why I cannot sacrifice SCA. Otherwise, there will be a large infarct in that area. And she is now asymptomatic. Her ptosis has improved completely. So that's why probably the sacrifice is not a good option. So, and in many cases, what I've seen, like this sort of an indirect flow diversion that do not work well, especially in the parapicum aneurysms or MCA bifurcations, where the vessel takes origin from the aneurysm itself. So it keeps on taking the blood inside the aneurysm and they keep growing. So might be it's not a very good idea to do that this way. So I'll just continue with this.
And patient was taking double antiplatelet continuously?
Sukalyan, your
yes,
double
the patients,
antiplatelet?
like, I usually use single antiplatelet both in the braided stent and also in flow diverters because I've presented it many times. Until and unless the patient is smoker, highly diabetic or bad vessels, and this patient was on ticagrelor. After 3 months, I changed her to clopidogrel, and because now I'm going to put another stent, I've changed her to ticagrelor again.
So single antiplatelet?
Yes, she was on single antiplatelet.
Fine. So now we are having coated stents and flow diverters. Are you going to get away from single also? Just asking.
I wish I could.
Yeah.
Okay, Sukalyan, you're ready with the catheter in the aneurysm?
Yes, my microcatheter is inside the aneurysm, so I just put my.
Can.
It was quite easy to enter in the aneurysm.
Yeah, cameras on the screen, please.
So, give me coils. Coil first. Yeah.
How does it work? This one is working. Hi, Sukalyan. Can you hear me? It's me, Vipul.
Yeah, hi Vipul. Good evening.
So, would you like to give a tip, someone? I mean, which wire did you use to cross the stent with a micro? And a particular micro you used?
This is synchro and headway duo.
All right, all right.
Yeah, and below is ballast and cat 5.
All right, all right. So,
yeah.
Okay, so that wire is in, yeah. So headway duo you use because it's profile easier to cross or what?
Yeah, because I don't have at this point of time headway 17. Otherwise, I prefer.
Yeah.
All my cases for coiling is headway 17. Sometimes, of course, SL10 and others. But now there is a very acute short supply of headway 17, so I use duo. And it's, of course, its profile is lower. Okay. Now, give me the. So we'll just take a road map now. Next. Yeah. Now, in this, we can see the origin of superior cerebellum, although it's faintly seen. Proximal marker of the capital.
So,
right, just somewhere here. Somewhere here. Yeah. So I've taken a 6 millimeter coil.
what coil is it?
This is from Optima from Volt.
Mm-hmm. How long is it?
This is 620. 620.
Perfect.
Yeah.
Okay, so Kalyan, as you keep coiling, we will leave you at peace and we will move on to Trivandrum. I think Dr. Santosh Joseph is ready at Kim's Hospital.
Right.
We will come back to you, Sukalyan.
Sure. Thank you. Thanks. Guru?
Can we move to Trivandrum, please?
So as you can see, these aneurysms have a lot more space than one would think there is. Just looking at the between the coil masses, there's usually a lot of space. So one would usually use a longer and a wider diameter coil than what you see on the DSA. Can you see the coil sinking into the in between the coil mass? So those spaces you're not seeing on DSA. Okay.
Okay, so this is the case from Kim's Health, Trivandrum. Dr. Santosh Joseph. We all know him. He doesn't need an introduction. He's been a pioneer in the field of neurointervention for a long, long time. This is a 60-year-old male with headache, bilateral MC aneurysm unruptured. There's a right side MC aneurysm. There's a small one on the left as well. So the plan is They're measured for possibly a double stent assisted coiling. So the hardware chosen are 8-French sheath, Neuron Max, DAC from Stryker, headway 21, and a Synchro 14 wire, and possibly a web. So either a stent assist coiling or a web is the option. So here he has chosen to do web on either side. So he is going to do web for the right as well as the left. Can we go live, please? Dr. Santosh.
Yeah.
Hello, this is Srinivasan and Dr. Bipul here.
Hello, Dr. Santosh. It's me, Vipul.
So the aneurysm is catheterized. You have already measured the aneurysm. What is the measurement?
What catheter are you using?
Around 7.1 millimeter in the lateral width. And the neck is actually narrow, which is around 2.8 millimeter. Mid body width and all is 4.5 to 6. So we are taking a flow, intrasaccular flow diverter like web 6/3.
Can you give us some input on how did you choose your size of the web?
What we are doing is in SL web. There are two types of web, SLS and SL. So what we have to measure is the total length and the width, and SL will compress little bit, and then we have to occupy the entire space. This is SL. So what we have selected is 6/3.
What was the width of
the entire space?
What was the width of the aneurysm you measured?
The neck is 2.8. 7.2 is the length.
So practically you oversized in terms of the width.
And then from the neck to the extreme fundus, it is around 6.6. 5.6. Yeah. So you are just preparing the web. You are releasing the web outside.
Can the camera show the preparation of the web, please?
Lights on. Lights on.
Can we have that as the main screen?
Are you able to see the web that is coming out?
I think the contrast of lighting is not so good. Yeah, now it's better.
Can you see that?
Make a zoom.
So in terms of preparation, what do you do? Can you please explain?
Basically to DAR, we need to deploy the come out of the delivery device and then put it inside the saline. So any small air bubble which is trapped inside the web will be eliminated.
Yeah, we are seeing better. Good.
Yeah. So it is prepared. Now we can start deploying. Lights off. Other lights off, please. Okay. Push the web inside.
Panelist, as he is getting ready to deploy the web, let him sheath it. Panelists, give your inputs on the catheter and your web experience.
Other lights off.
Can you hear me? Yeah. Basically, in terms of sizing of the web, how we exactly do it is we undersize the web in terms of height, and we oversize by 1 millimeter or 1.5 millimeters in terms of width. Because web is a device which is going to fill the entire aneurysm, not just the neck. It is not like a contour. So basically what happens is you take a shallow device, but a broad device, and the moment you deploy it inside the aneurysm and you pack it in, what it loses in terms of width, it will gain in terms of height. So how you deploy the web is the catheter that is most often used now is a VIA. It's a VIA 21 or a VIA 27, depending on the size. So for this, I believe he would have taken the VIA 27. And SL, so SL means that the web is the rectangular web, and SLS means that it is a spherical one.
Yeah, so at this stage, we can see the web is reaching the catheter tip, and it is important that catheter doesn't jump, all right? So one would go slow at this stage so it doesn't jump. And usually it's a very safe device to use, but there are some reports of when whole thing can jump and can cause a rupture. So you see here is being very, very careful, very slow and deliberate, so as to have a stable microcatheter position.
Yeah, the initial portion of the web is coming out. The catheter is kicking back. I think it's that portion is stiff. Once it flowers out, I think it softens.
Yeah.
Dr. Vipul, how far do you allow it to kick back? Dr. Santosh, as you are deploying this at this stage, you are looking at the roadmap or you looking at the plain fluoro?
Plain fluoro right now, because roadmap may mask some of the finer aspects of the neck. Now we can come back to the, I think is deployed well inside. I'll do one check angio. Amount of stasis is seen.
Can we look at the DSA pictures? Yeah, now we can.
So what we are trying to do is possibly we'll do a expert CT, high resolution stent CT, and then find out how it is opened out, or a vaso CT. Vaso CT is much better.
So that is intracircular devices. To visualize them, this is very useful to have expert CT or an equivalent, whatever, Dyna CT and Vaso CT, that one can clearly see how it is related to the neck before we want to detach it.
So as they are doing the expert CT, should we move back to Calcutta?
Yeah.
Can we move back to Calcutta?
हो गया ना? We have time. We'll do it. You are listening to me. Each and everything. The moral of the story is each and everything. You should see.
This is ready. I think the case from Udaipur, Dr. Atula Bajpai is ready as well at Pacific Medical College.
Yeah. This side? Okay.
So I'm just going to present the case on behalf of Dr. Atula. So it's a 70-year-old gentleman, recurrent left fasciobrachial TIAs. He's a diabetic. He underwent a CABG few months back. And we can see some small hits on the right side. And DSA predictably showed a severe stenosis at the origin. The left ICA is totally occluded. The patient is loaded with dual antiplatelets and planned for right carotid stenting with distal protection. That's the hardware. What do you say?
Okay, so he's planning an exact stent with an emboshield now. So we'll move over to Udaipur.
So suppose we discuss with the panelist, how many days after the symptoms would you like to do a stenting? Immediate? Symptomatic stenosis, minor stroke or a TIA, but some infarct. So after how many days of event would you like to do it?
Yeah, if it is a recurrent TIA, then yes, it should be as soon as possible, maybe within 24 to 48 hours. If it is a mild stroke, we can take maybe around 2 weeks. And if it is a moderate to severe stroke, we can wait for 6 weeks. So this is...
Yeah, so as long as small DWI hits, we do it soon. Literature, we also say as soon as possible. Literature says 3 to 5 days is the right time to do it. My assumption is first 1 or 2 days, of course, it usually gets into workup and everything. And what we really like to look at in these cases is whether there is any floating clot by any chance, because some of these are ruptured plaques. If we see on DSA or CT angio fresh clot, then I usually wait a little bit, clear it up, and then do the stenting. But of course, in a case like this, very severe stenosis, opposite side occluded, and looks like a clean stenosis, so one would do it soon. And patient was on antiplated before when the event happened. That also tells us whether, that patient probably will not tolerate. So would you be worried about hyperperfusion here? I mean...
hyperperfusion is, if one is carotid is occluded and another is severe stenosis, hyperperfusion is, you have to be very careful, and of course you have to keep BP towards lower side to avoid hyperperfusion.
So at least in our center, we like to do TCD with vasomotor reserve testing beforehand. That also tells us whether likely to have some issues or it's done. Wow, before we went to do, it's already done. That was quick. When Dr. Tulojam said ASAP, I think Dr. Tulojam decided next 5 minutes.
No, there was an issue, I think, because the patient was uncooperative under local anesthesia while we were waiting. He was in the queue.
All right. No, of course, I understand. So
that is truly understandable.
Maybe Dr. Atulab, we can ask him to describe some of the steps. Did he pre, post, what did he do? So that
he's just going to play all the steps. He has recorded all the steps. He's going to just play it out.
Okay.
Atulab, can you... Hi.
Yeah. Am I audible?
Yes, you're audible. You're on the screen.
Yeah. So basically, I mean, he's a 75-year-old male with recurrent TIA, and he underwent a CABG couple of months back with poor ejection fraction. So he was having recurrent TIA, bilateral MC-38 infarcts were there, watershed infarcts were there. So one ICA was completely occluded, and other right ICA was critically stenosed. And he's elderly man fasting from morning under local anesthesia, so I had to just quickly do that. I'll show you steps. I had taken a long sheet here. Can we just, can you show the screen? So, a long sheet, 7 French, that we have taken up in the right ICA.
So this was a Cook shuttle, correct?
So he's taking it coaxially, which is the safe way to do manipulate in the aortic arch and atherosclerotic. I think there's a diagnostic catheter which he has taken over a wire and then the sheath in, because you don't want to take these sheaths over wires and these are stiff systems. And we at least like to watch in the other plane, and sometimes if there's any issue, take the wire into the ECA. You don't want the wire to jump around into the stenosis as well. All right. So if there is an issue in navigation, park the wire in ECA and then do all of these steps. So that is useful.
So can we go to the next phase? So once the sheath is in place, you can see this is today's, the DSA image was a couple of days back. This is today's image.
Yeah, quite critically stenosed.
Yeah. But you can see left side is only partial ACA filling. That means from the left side, there must be a PCOM then. All right. So it's useful to know when you're worried about
compensation from whatever basilar territory.
Great. Because that is very comforting. It will sort of decrease the chance of hyperperfusion, you know.
True. And then we have gone up. These are the steps. We have taken this ambush shield because it is a acute stroke. With probably, I thought initially there is a thrombus there also, but so we have taken ambush shield, which is not the case every time we do.
Okay, yeah.
So
if you can
this
see
is
that,
how we have placed.
Yeah.
This is before opening that.
Atla, what your strategy in placing the filter? Where do you want to place it?
Yeah. Usually, I just need to, saturate a straighter vessel with an adequate distance from, your distal rear wire tip as well as your intended placement of stand device.
Yeah. So
otherwise, there is more possibility of dissection and those things. So this to me appeared, pretty safe area to place filter. It's by eyeballing most of the time.
So usually 3 centimeters with
That
this
is
system.
what is recommended.
What would
Yes.
you need? So if it's between the margin where you want to park, and so that you can place a stand. Of course, these filters are free. So even if it comes down, you can push it with your stand or a balloon upstairs. It's okay.
Yes.
But it's good to see, if you see, he has kept the wire tip under view. In fact, most of them when we are exchanging it, your eye should be on the wire tip and it should not be moving around. So that is important to have it under view and your eye there. Okay. Are we doing angioplasty or what?
I thought it was a pretty smooth passage, and I thought I could take the stand device up with this much of passage. And
Okay.
I initially I was planning for pre-dilatation, but eventually then I did not do that. And this one was placement of this device. There was some spasm in the vessel.
So that happens at times. One need not worry about it. Once you finish the procedure, you take out the filter, the spasm just goes away. We don't like to give
Yes.
vasodilators here because we are worried about hyperperfusion at one level. So you don't want to dilate the arteries or anything. Usually it just resolves once you finish the procedure. So carotid stenting should be done fast.
Yes.
I say one procedure we should do like cardiologists do their procedures. Fast, quick, fast steps.
And then we had, of course, done the 620 Vitek. We have done dilatation.
Why 6? Would you use 4, 5, or your usual practice to use 6?
Sometimes 5, 5.5. It was fine at 5.5.
All right. So usually we don't do with 6 almost
6,
ever.
yes.
But maybe in this case the artery is supplying both hemispheres. It's a dilated artery and it did need it. So
Yeah.
we do it by 4 or 5 post and so at this stage before you remove the filter, we always like to check with the patient. Clinically check that everything is fine. Yeah.
So patient is under local anesthesia only. So obviously, I mean, he's a CABG patient with poor ejection fraction, so we have to use less dye.
Yeah.
Atropine we have given before, dilatation also. So he maintained there was a slight drop in pressure and rate, but he was clinically fine. We were assessing him clinically at the table itself. So he was doing fine.
I think that's a filter retriever catheter being taken, if one can see it.
Yes.
You take it up to the filter and then we withdraw the filter wire to take it in, right?
Yes.
So even partial closure is enough to take it out. We don't try to squeeze it in completely if there is any debris there, So, and these are closed cell design, exact stand is closed cell design. So it's very easy to withdraw the filter even partially closed through it. So, yeah.
So because there was a spasm, so quickly we had to take it out.
Yeah, it's okay.
And then, as soon as you take it out,
the spasm will resolve. Usually it's not a worry and very rare to have any dissection. And you see another angiogram is completely gone now.
Maybe I can, because there was a possibility of the tandem lesion in the beginning. I'll just take a complete angiogram.
Yeah, that is.
So after stenting, do you wait for some time to look for any clot formation, how the spasm relieves? How long do you wait?
I'll take another shoot. आप हिलना नहीं, सांस रोक के रखेंगे, हिलेगा नहीं, है ना? सांस रोक के रखिएगा, थूक नहीं कटेगा, हिलेगा नहीं.
Looks good.
Looks good.
So which drugs have you used? US aspirin and Plavix or something else?
Yes, sir. Ecosprin 325. Nowadays we don't have 325 to 300 with clopidogrel 75.
All right. So anybody else, anyone here on the dais or elsewhere who uses any other drugs besides aspirin and clopidogrel? I mean,
Same.
Brilliant.
Ticagrelor and ecosprin is standard.
So ticagrelor, of course, will have less resistance, and question will be whether the balance with the slightly more bleeding complication. We have particularly seen systemic bleeding issues at times when we use ticagrelor, but it's one's choice. I know some international centers. So Plavix will have 30% chance of resistance. So we always do a check angiogram to 20-25 minutes to look for any clot formation. There's some M1 narrowing probably.
Yeah. So this was initially we thought, I mean, this is tandem lesion, and probably
can we see the previous run, the carotid stenting run, the previous one?
Yeah.
What is that?
Are we having
little contrast near the stent?
Yes.
What's that?
Must be ulcerated plaque.
Yeah. So sometimes even plaque
ulceration
dissects. Tight stenosis, plaque dissects, and contrast may seep out a bit, but it doesn't matter at all. It will just heal up. So we have seen in some cases we have seen this.
Yeah.
The thing is, we have seen in our experience 10 to 15% of patients in 20 to 30 minutes, you may see some clot formation if there is clopidogrel resistance. Then we give injectable drugs, and in my practice, we usually make Plavix BD. But if still we have a doubt, then we switch to ticagrelor.
Dr.
Great result.
Pre-plasty would be better or post-plasty?
Sorry?
In this case, the pre-plasty would be better.
Oh, I would have done pre-plasty.
It was severe stenosis. So.
I would have done pre-plasty. Again, I mean, there is nothing like known, but long time back when I did my initial studies of carotids, when they did microemboli study on TCD, they found that more emboli actually in post angioplasty. So for me, that logic, slow dilatation is better. And so I do pre-plasty, usually by 3 or so, then place a stent and then do a post. Post, I wouldn't done with 6, 4 or 5. It's a big artery, then maybe 5, but I don't usually use 6. You don't need to actually. We will have more baroreceptor issues maybe, and it doesn't really need. And these stents tend to open up a bit more with follow-up, not less. Yeah, Ajay.
Yeah.
Anything else you would have done?
Yeah. You do pre-plasty in almost all the cases, or when
in such a tight stenosis?
Tight stenosis.
Tight stenosis, but if it is not so tight, then but most of the cases
because with pre-plasty we are having increased chances of, even with the distal protection device, we are having chances of migration of some.
But it can happen because even
plaque and
stent struts, when they sink in suddenly into the plaque, that itself can cause plaque injury as well. So that is an interesting point I'm saying. Maybe I haven't read the literature for a while now, but long time back when I did my reading on TCDs, they found more microemboli in post-plasty stage. So microemboli can happen at guiding placement, wire crossing, pre-plasty, stent placement, post-plasty, right? And you can have microembolism at all those stages, but they found more at post. So my logic was that means pre is better rather than doing a drastic 4. But I have known of some people who do only straight away stent and post. If it is calcified stenosis, it's very important to do pre. You should know that the plaque is really opening up before you place a stent, and then if there's dense calcification, you have issues in opening it up.
Yeah.
But again, everyone has their own practice, and so it's all right.
Valid point, Dr. Vipul. I think there is a little change in the plan. I think we will say goodbye to Atulab. Thank you, Atul. Wonderful case. Loud round of applause, please.
Yeah. So just a word. I mean, this in the last slide. So this is carotid stenting. I mean, we have this one paper coming in stroke in a couple of weeks. So that's for moderate or no stenosis, less than 50%, 30 to 50% stenosis. So that's a study, comparative study of symptomatic and asymptomatic side in 80 patients. So this will be interesting paper. I mean, I would request you to read about it, because it is not the degree of stenosis but plaque morphology or a vulnerable plaque that is more important for reducing events. So that is one study from our center of 80 patients. So please do read it.
Sure. Thank you, Atulab.
Thank you, Atulab.
Wonderful
nice
case. Thanks for sharing with us. And we have a little change in the plan. I think Sukalyan is still coiling, and Dr. Santosh Joseph is moving to the other side for the second web. In the meantime, we can have the talk from Laurent Pirot from France, surface modified flow diverters, preliminary clinical experience and current evaluation.
So good afternoon. Congratulations for the very well organized meeting, very interesting meeting, on the very interesting cases we have seen this afternoon presented by Indian teams and also European teams. So I will briefly show you the current evaluation of a coating study, which is dedicated to the evaluation of a surface modified flow diverter. So are my disclosures. So a brief word regarding surface modified flow diverters. You know, the goal of the modification of surface is to improve navigability of the flow diverter. It is what is supposed to do, for example, Fredix from Neurointervention. The second goal is to reduce platelet aggregation on, by the way, thromboembolic events. It is a case for Shield Medtronic and HPC from Wallaby Phenox. Another goal is to stimulate endothelialization from, for example, we have the CD31 from BALT, which is currently under animal evaluation. So we have these different goals of the surface modification. Maybe there is an interaction between endothelialization and antiplatelet aggregation, as was suggested by some physicians. So Phenox was developing HPC coating, which means hydrophilic polymer coating. I am not a specialist, but briefly, it is a glycocalyx-like surface modification. Glycocalyx, we have it in the brain arteries, and it prevents platelet aggregation on the arterial wall. So the HPC coating is similar to glycocalyx, and you know, some lab evaluation and also animal evaluation was showing that it's effectively preventing platelet aggregation. So just to show you some cases we have done, here it's a ruptured IC treated in 2015 with Fred flow diverter, but you see that in 2020 we had an aneurysm remnant, so we place a second flow diverter in the first one. In the Fred, so we place a P64 MW HPC under dual antiplatelet therapy at that time, which was a 5/18. At the end of the procedure, we'd still have some flow in the flow diverter, but after 1 year, 14 months, we had a complete aneurysm occlusion. Another example here, unruptured IC aneurysm treated with P64 MW HPC. No coils in the aneurysm sac, and you know that after 12 months we have a complete occlusion of the aneurysm. A small, very small MC aneurysm may be a blister-like with subarachnoid hemorrhage. We try to do a coiling, but indeed you can imagine that even with the smallest coil we have, it was very difficult and not possible, by the way. So what we were doing a kind of indirect treatment, indirect flow diversion by placing a P48 MW HPC 3/12, and you see the flow diverter in the branch, and at 12 months you see that we have a complete disappearance of the aneurysm. So preliminary results, we were conducting a P48 MW HPC series under dual antiplatelet therapy with another hospital in France, in Lyon. We were including 28 patients with 29 aneurysm with various location, but a lot of bifurcation aneurysm. Most of them were unruptured or recanalized. Treatment feasibility was 100%. You see that we had relatively few complications, 7% thromboembolic complication, but no clinical worsening. Morbid mortality was 0, and anatomical results were quite good at 6 months with 87% of complete aneurysm occlusion. There was another series presented by Professor Enkes and Victoria Elstern in Borum, 100 patients, 128 aneurysm, treated with P64 MW HPC, but this time under single antiplatelet treatment. You see that there were very good anatomical results, again, with at 9 months complete or near complete aneurysm occlusion in 88% of cases. There was no mortality, no morbidity on this series. There were no thromboembolic complications, neither hemorrhagic complications. There were some technical issues like foreshortening, collapses of the flow diverter, or a dissection of the ICA. There were also some post-procedural complications, singularly before 30 days, with some ischemia or some insane thrombosis. There were very few delayed complications after 30 days in 1% of cases with intraparenchymal hemorrhage. So what is COATING study? COATING study is the first randomized controlled trial dedicated to the evaluation of surface-modified flow diverter. The goal is to compare the standard treatment, which is the use of a bare flow diverter under dual antiplatelet treatment, to the use of a surface-modified flow diverter, P64 MW HPC, under a single antiplatelet treatment. So the design is, is an adaptative design, which means that the primary hypothesis is non-inferiority, and the secondary hypothesis superiority of the use of surface-modified flow diverter under single antiplatelet treatment. What is original in this series is that we are using as a primary endpoint the number of spots on DWI imaging, just to reduce the number of patients. And indeed, we have a lot of secondary endpoints to evaluate safety and efficacy of the treatment under single antiplatelet treatment. So the number of patients is expected to be 200. The maximum number of centers will be 25. So the first patient in was in Q3 2021 in France, and the last patient is expected at the end of the year, on the end of the study, and the final report are expected in 2025. So randomization, we are just accepting prasugrel or ticagrelor. You know, there are 30% resistance to clopidogrel. So the reason why clopidogrel is excluded. So if you have the coated flow diverter, you will have during 6 months prasugrel or ticagrelor, and after 6 months you stop this medication and you will have 6 months aspirin. If you have the bare flow diverter, you will have prasugrel or ticagrelor plus aspirin from the beginning, again for 6 months, and after that 6 months of aspirin. So here are the committee of the studies. We have a lot of independent committees to evaluate the results as usual. Committee for clinical events, imaging core lab. On the current status of the study started in most countries involved in the evaluation, you know, France, Germany, Switzerland, Italy, and UK. And we will have also Israel and on that soul, sorry. And you see here the current status of the study. We already have included 79 patients. We will have an interim assessment after 85 patients, so very close. And so in conclusion, you know, surface modified flow diverters, as was shown today, will potentially enlarge indication for flow diversion. As of now, none of the surface modified flow diverter has been properly evaluated, singularly pipeline shield. So coating is the first multi-center randomized controlled trial which is comparing a bare flow diverter, P64MW, under dual antiplatelet treatment to a coated flow diverter, P64MW HPC, under single antiplatelet treatment. And indeed, this study will potentially change our indication for flow diversion. Thank you for your attention.
For evening, you know, in evening when we interact, and
yes,
thanks a lot for your talk. Yeah, so we can go back to Sukalyan.
Go to Calcutta live, please. Sukalyan, we are back with you.
Yeah.
Tell us, what have you done so far?
I have just finished the coil and then I'm taking the catheter. I'll show you the final run after coiling. Show the final run. Last one. Yeah. This one.
Can you show us the screen, please?
Yeah, that's pretty nice coiling, Sukalyan.
Yeah. Right, so I could not put more coil because it was encroaching, but the rest part of the aneurysm is pretty well packed. So now, what is your advice? Whatever advice you give, I go with that.
That was extremely smart. So
yeah, the house has given its advice much earlier.
The problem is this aneurysm,
they'll stick with the same.
Yeah, will grow, and that's a truth. Ideally, yes, one would think about placing a flow diverter now because you don't want to go back again and again. One can place another stent, but my gut feeling it will still come back, and then you go for a flow diverter. Or we place a flow diverter now, but you are placing on the basilar top a flow diverter within a stent. I would think about slightly oversized flow diverter. Okay, so in these cases, when I'm trapping arteries, if I'm going to place a FD device, I slightly oversize so not to have too much of flow diverter effect as well. So any other, made my commitment or statement, Sukalyan. So now we can have opinion from our panel.
Ajay, stent is already there. If it comes again, then we have no choice other than FD, a small FD, because the stent is already there.
Yes.
So a small length, not
Rahul?
diameter. Yeah.
Small FD, sir. Small FD.
All right.
I think patient had third palsy which has recovered. So chances of rupture of this aneurysm is not very high. So why to leave here only?
The only problem is, you're right, it's a fair choice, but we are just delaying the inevitable. This will come back and this will grow. So either we tell the patient after 6 months, this is 100%, whatever packing you do, it will be looking much worse. So yes, one choice is you tell the patient, we live with a small neck, watch it. If it grows, then place the FD. It is always a choice.
Yeah.
See, if on imaging, Lochan sir, if on imaging the aneurysm is covered, the dome is covered, and recanalization is just at the neck. But when the recanalization is at the sides and you are having the domes, they are very much liable to rupture again.
It is never
So
ruptured.
I can see Rajiv right in front of me and he was smiling.
See.
So what's your opinion? What would you do?
It was unruptured aneurysm. It was present with the third palsy which has recovered. So
That's also very smart. So any other contrary opinions? I mean, we have got neurosurgeons here, right? What is this?
People, can I?
Yeah,
See,
please.
again, you expect it to come again and again. Why don't you go ahead and clip it out?
That's the point I just raised, because without coiling.
No, there appears to be still space between the parent vessel and the aneurysm.
And it's superior cerebellar, it's not basilar top. So
And this can be clipped 100%.
yeah,
with
so
no recurrence.
So actually,
I can watch that.
At that stage with single stent without doing further coiling, clipping actually is an option, because these are not that difficult as compared to basilar tops.
And that's the end of it. That would be the end of it.
And it's cheaper.
Exactly. That's
Yeah, it's actually a fair choice. It's not something, because flow diverter, long-term interplatelets, trapping the arteries. So if you have a good vascular neurosurgeon who are doing it regularly, that's the problem nowadays. We don't have so many people doing it regularly. One should think about this option, or at least before placing the flow diverter, send the patient to neurosurgeon, get an opinion before jumping. Like I jumped in without taking his opinion, right?
Dr. Suresh Dugani.
no problem, Vipul. No, see. No, Vipul, we are a minority here.
But
no issue.
But did you notice? I proposed clipping before even instead of I said neurosurgical opinion, because superior cerebellars are not that difficult to clip as compared to basilar tops.
Even unruptured
And
aneurysms?
again, Vipul, I would like to
Unruptured aneurysms?
one more thing here.
Or ruptured?
If Ajay, my words were refer to neurosurgeon before placing FD.
No.
I didn't say clip.
My
I
question
said-
is very much clear. I'm asking unruptured aneurysms.
No,
If you send it for clipping.
I said it's an option in this. See, Ajay, we are here and we should have an open mind that there is an option in very good vascular neurosurgeon hands before doing the coiling, because it is going to grow. It's an option. Okay?
And again, see, here the issue here is when we have coiled it twice and we treat it as unruptured aneurysm itself. It's unruptured aneurysm.
Yes.
Straight away, number one. Number two, if you look at the long-term results of such aneurysms requiring more and more time coiling, better to go ahead and do it once and for all.
All of us.
And the patient is young.
So let's ask Sukalyan, what is he doing?
Sukalyan, so you had many options here. One of the option is not in your hands. So we'll look for your option. What are you planning?
Yeah, unfortunately, I don't have that competent neurosurgeon here who wanted to clip it. And I don't know how many of you will clip when the patient is asymptomatic and when you can guarantee that there will not be any problem with clipping. That's very important. It's very easy to say that, you will just go and clip, because this is just by the side of the basilar top. So it's nothing bit different from the basilar top. So, if you are 100% sure that you can clip it without any harm to the patient, because the patient do not have any deficit, then it's very easy to clip. Then good to clip. But here, what I think is I'll not put FD here because I'm a bit scared about those large perforators, and so I will. What I thought is I'll put another Leo, short Leo, bit oversized, and then just see what happens.
That's also a fair choice because with two stents, we'll have flow diversion, and one can wait and come back to FD or any other options later on.
But Sukalyan, given that there is a vessel arising from the aneurysm, that is from the side wall of the aneurysm, usually even when we put a flow diverter, when there is a side wall which is draining, the aneurysm tends to remain for a long time or tends to regrow and recanalize because the flow is not obstructed, the flow is established. So what's your take on that?
Absolutely, this is a very valid point. That's why initially when I started the case, I told you that this is not a very good way of doing indirect flow diversion because we have seen in many other areas, not only this, in the pica region, when you do the indirect flow diversion, MC bifurcation, periapical, and so on and so forth. So it's not a good one, but it's a fairly good one. That's what I can say.
Yeah, so it takes time in these cases. One has to be very patient. As long as even the aneurysm doesn't grow after FD, it's fair. And maybe 2 to 3 years, if the artery develops collaterals, the artery has to regress. That's the only way aneurysm is going to go away. So one hopes that slowly develops collaterals because of the FD covering its origin, and it regresses, and the flow through the aneurysm reduces. So it's a 2-3 years prospects, but as long as it doesn't grow, patient is stable, they don't rupture again. And the key is that yes, so placing a stent, of course, is the safest option here.
Dr. Sukalyan.
Sir, just wanted to ask one question.
Yeah.
That stent was actually required in this case in the first time? Because, this antiplatelet given during the first surgery, it has something to do with this recanalization. Because I think neck is quite good for primary coiling only.
So,
yeah, and as you have talked about, the basilar top and this aneurysm, the clipping thing. These aneurysms are actually simple to clip because the SC aneurysm, especially this area, is basically perforator free. So anyone who is into the clipping knows that if you want to clip the posterior circulation aneurysm, this is the aneurysm that one should start with.
So Sukalyan, you will finish the stent in the PC itself? That's the plan?
My plan is to put the stent in the PCA, not coming to the basilar.
So that's really a good thing here, that we have a margin. Even if you want to place a FD, one can try just only in the PCA, which is much safer than trapping the arteries in the basilar top region.
Dr. Sukalyan, did you thought of putting intrasaccular device if O21 catheter goes through this stent? I believe that might have solved the entire problem of the flow diversion, that to inside the aneurysm, and keeping the SC also patent. The only this thing was if O21 catheter is going inside this residual aneurysm.
Yes, looking back, actually, I was discussing this case. Probably it would have been the best way to put a contour device.
Yeah.
And coil it. That probably would have been a better choice.
Yes, yes.
Sir, I just want to ask one question.
We will, 1 minute. I think in Trivandrum they are ready. We will just go and come back here. Sukalyan, we are going to take a break from you. As you get ready to put your stent, we will come back to you.
Thank you. Thank you.
We'll move on to Trivandrum, please. Dr. Santosh, we are back with you.
We are catheterizing the left side again.
So you can see the very high quality roadmap. And this high quality imaging is particularly useful for intrasaccular devices, as I mentioned, not only, because when you're placing, you want to see them well. Again, you can see he's taking his time to enter the aneurysm, which is the key to be safe. We need not really rush in. Of course, with his experience, he could control the movement so well without the wire. And sometimes, yes.
What guiding catheter do you have, Dr. Santosh?
Guiding catheter is Sophia 5F.
Okay, which size of web are you planning here?
70. So we have calculated the size 3 into 2.5. SL.
SLS, can you mention the size again? Sorry.
3 into 2.5. Method. 3.5 by 2. Where is it again? Let's start. You correctly? 3.5 by 2. Now, preparation of the web.
So, any other options? I mean, among the panelists, would you use the same system, Sophia?
You can see here, very thin web is kept there. Some one bubble of air has come out. That's how we de-air the web. One more bubble has come out. You see.
Yeah, we are seeing it very well.
No more bubble. Okay. Lights off here. Other light off. Push. Okay. X-ray disabled.
While taking the web up there, Dr. Vipul, can you comment on the chances of the catheter kicking back out of the aneurysm? When you're taking the web up there, when it takes the curves and turns, what are the chances of the catheter kicking out of the aneurysm? Especially when you're working with such small aneurysms.
Definitely there is a chance of kicking it out. But I think with playing around a little bit, I think we will be able to get it inside.
Your catheter seems very stable.
Carry on to the forum. Slightly retracting the wire. And carefully advancing the started expanding. You can see it in the lateral. Okay.
Attention everyone, my humble apologies to intrude in between, but we do have a special announcement. We have a flash workshop starting at 6:30 p.m. So if you would like to be a part of it, you can check out Striker Tech Suite. I repeat, for the flash workshop starting at 6:30 p.m., you can proceed forward to Striker Tech Suite. Thank you so much.
So we'll do a expert CT to find out whether it is adequately expanded, whether both branches are filling, there is no occlusion of the branches, there is no other issues. We'll do an expert CT now to find out.
With what we see, it looks quite impressive. Such a tiny aneurysm, perfectly placed, looks quite impressive. We'll wait for the expert CT. In the meantime, I think we will move back to Calcutta and come back. I think Sukalyan is ready with the stent.
Yeah, Santosh sir, good evening. You have changed the diagnosis of patient from MCA mirror aneurysm to mirror web.
Ajay?
Yeah.
Okay, I recognize only the voice.
Yeah.
I'm not able to see you, but I can recognize my voice. Okay. I can see you.
Yes, sir. So I was saying you have changed the diagnosis of patient.
Yeah,
from mirror aneurysm to mirror web. We are having.
Good. So as you do the expert CT, we will take a break from you. We will move on to Calcutta and come back, sir.
Sure, thank you. Also CT, na? Reduce the contrast.
Which one you have to quit?
So Sukalyan, which size stent you are using?
Yes.
Hi Sukalyan, we are back with you.
1.512.
Yeah, we are back with you. So what is the stent you have chosen?
0.512. 0.512, yeah.
Okay.
I think that must be the shortest length available.
Shortest, yeah. So I'll just take the stent inside now. Coming? This is what we do now. So I have placed gamma 17. Please. So, it's the distal clip. So start from there. I think, yeah, so we can see that stent is in place, and what the calculations, what I could understand is that with respect to the previous stent, we will start just a little bit proximal, halfway of the first buckle, and then it probably will reach just at the bifurcation.
Can the inset of surveillance image be moved down in this screen so that we can see the stent delivery clearly?
Can you move that thing down?
So the stent is from here.
Inset down.
Yeah. So can you see the stent now?
Yeah, we can. Only think the digital end they have put on video of you, which doesn't. We can actually remove that video because we are not really seeing anything except for the backside.
Oh yeah, just
Yeah. This is now we can see it very clearly. Yeah.
move that actually. Okay, so I've just placed it with the distal marker. And then I come back gradually, slowly.
Compared to stenting in a normal vessel, stenting inside a stent, do you find any difference? Is there a resistance? Is there a jump? Do you feel any difference?
Not really, not really. It's easier. What I feel.
In this, at least
The previous
it's a pretty straight anatomy.
Intimalized
So
till now.
the catch here is to visualize within the other stent that is really expanding very well. So,
Yeah, that's true, that's true.
so good angiographic system.
So now it is more or less a half of the first one. Now you can see that it's opening.
Yes, we can.
Because
can we see in the fluoro? I mean, will that show us better?
The native image.
The native image.
Or we can just come out of the fluoro and fluoro, just normal fluoro. Out of roadmap. So I'm going out of roadmap and just do only fluoro.
That would be better.
Yeah, so now you can see that the halfway I wanted to start. And maybe I'll just pull it a little bit proximal. Now it's opening. I'll come bit proximal. I'll start maybe here. Right? So now it is opening nicely.
Yeah, we see it opening well.
See it, yeah.
And got pushed. Okay. Yeah. Neck is somewhere in the coil also. Yeah. We'll come back.
I think this happens with the shorter stent. You want to be very, very precise. You don't want this little forward movement, correct?
And it's good to take your time and be sure where you want to deliver it, and that's the right way to do it. And that's the advantage with these stents. You can retrieve, reposition. So
Now it seems even better.
Yeah. So just deployed it. It's still not detached. And just just twisted with the taut a bit.
Okay, very nicely done, Sukulyan.
Thank you.
Nicely done. And do you always go through the stent before pulling out the inner wire?
Yes. There is, because I'll keep it now, the stent, the catheter, because if I find any clot or something, it is easier for me to go and dissolve it. So it gives some massage to the catheter. I know pretty sure that the distal part is opened really, and at the same time, if the catheter is there, you're pretty sure that if any clot lysis is there or required, it's easier. So I'll just wait for another half an hour. That's the standard after all the stents, and then I'll do a check angiogram. And once I find everything is okay, then I'll come back.
When you put a stent, do you check your ACT levels and do you keep them higher?
Yes. So now the baseline was 149, and it was, and during the procedure it was around 200.
So,
yeah.
Okay.
So most important, of course, are the antiplatelet drugs. And yes, ACT also we like to take it around twice or at least 250. But most important is the antiplatelet drugs. And as Dr. Sukulyan mentioned, monitoring for next 20-30 minutes is important because you will know any trouble happening now rather than later in evening or night. Usually, if we can cross easily with the micro is fine. Otherwise, we don't really, in flow diverters, we always like to cross. In stents, I do it whichever way, doesn't matter much.
Right. So let's see how it works.
Yeah, follow-up will be interesting here,
Do check angio after 3 months.
But it's a difficult aneurysm, and I think you have done very well. We can all sort of give him a hand.
Thank you very much, and I'm thankful to all of my team here, the anesthesiologist, my junior consultant, Dr. Bapi, sisters, brothers.
Great. Yes. Team is so important in these cases.
The fellows are there with you, so they're probably also watching you.
All right. So we look forward to seeing you.
See you tomorrow.
See you tomorrow. Bye-bye.
Thank you so much.
Thank you, Sukulyan. Give a big round of applause for Sukulyan.
Team for this wonderful event.
So
now we are back, I think, in Trivandrum.
I think Trivandrum, they have just placed the closure device. I think we are. Dr. Santosh, we are done.
Dr. Santosh, can you hear us?
Hello, I am Dr. Manish here. He has just left the lab and we have finished the case. We have closed the artery with an angiosync device. You should have seen the last run where the aneurysm was well occluded. The device is in good place, and both the branches of the MCA were well filling.
Can you show us the Dyna CT or the expert CT that you have done? Anybody in Trivandrum holding the microphone, can you just communicate with us?
Yeah, we're just trying to load the scan.
Here you go. Yes, we can see you. We are not able to hear you.
Yeah, we're just waiting for the scans to get loaded.
We are not able to hear you.
Just speak a bit louder. Yeah.
We're waiting for the scans to get loaded.
Yes, we can hear you now. Thanks.
So this was the final Dyna CT which we did. As we come on, this patient was an unruptured aneurysm, so we don't expect any problems.
Can we see the screen? Can we see this?
CT also does not show any new hemorrhage.
Can we see the CT screen, please? Can you focus the camera on the screen?
Can you see the screen now?
Yeah.
Yes, we can.
Yeah, so these are the two web devices on either Sylvian fissures. And there is no subarachnoid hemorrhage, no other hemorrhage. So the scan looks good.
All right. So we also have expert CT angio or basal CT?
Yes, we do have a basal CT. That's a basal CT which is getting loaded. We can see the placement of the device.
Yeah, there is a lot of reflection. Can you turn down the room light? Thank you.
Yeah.
Yeah, we can see the device very well, perfectly placed.
Both the branches are filling well. You can zoom it for you. You can see the tail of the web right at the bifurcation. This is another projection.
Yeah, great. Thank you.
Looks good.
So these are very comforting images before we detach that one is in right place and not missing anything. Yeah. Thank you. So I think.
Thank you. That's a job well done. And any
again,
big round of applause for the
Dr.
Trivandrum
Santosh.
team, Dr. Santosh Joseph and his team.
Yeah. So Gaurav, we close the session.
Thank you from Team Trivandrum.
Any final comments, Dr. Vipul and the chairpersons?
I think we have been talking a lot. So, Rahul, Ajay. All right. Yeah. So these are nice cases. It takes a lot of effort to organize and do live cases. And I think a lot of credit to Gaurav as well to make all this effort. So let's give him a hand. Yeah. All right. Thank you.
Thank you. With this, we end the session.